Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have a hearing scheduled that we'll be getting to momentarily, and then we have a number of bills that we're going to be meeting in executive session to address. But before we do any of that, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill, or the only bill we have scheduled for a public hearing today, is House Bill 1712. And to introduce this, I will recognize the prime sponsor, our Representative David Nagel. Good morning.
Thank you, Mr. Chairman, honorary members of the committee. Just to remind you who I am, I'm David Nagel. I represent Belknap District 6. I'm also the chairman of the Integrative Pain Medicine Committee, formerly called the HB 66 Committee, and that's what this bill is about. We heard this bill last year, and it passed this committee unanimously, the Senate unanimously. And in front of you is also the report for the committee. The only thing that HB 1712 changes from 66 is the date. We're asking for your permission to continue our commission for another year. To remind you what this is about, as you are aware, there is and was an opioid crisis, and one of the recommendations nationwide on dealing with that was to increase access to provide alternative therapies for pain, which sounded like a really wonderful idea. The minor problem is we don't provide any access to any of that. So I've been involved in a nationwide effort for almost 30 years to try to help solve that problem. And we haven't really been able to do it in a cost-effective way. I actually wrote a paper on barriers to resolving this issue that's 5 pages long that I presented at a meeting. And a lot of them are unnecessary barriers, people guarding turf, things like that. And so we felt that it was really important that in a statutory way, we develop a program whereby we provide access to these therapies in what we call an integrative way. And what that means is that we're concerned about fragmentation of care now, where the chiropractor does this, the doctor does that, the massage therapist does that, but nobody's talking to each other. And we know that system doesn't work. So, and we've known since 1984 that when those groups of people work together, it does work. The other thing that was important is that we do this in a New Hampshire way. People have done this all over the country. The problem is when we looked at this, it didn't seem their models worked well. And I'm really an advocate of community-based care, which means that we include all the providers in the community in an integrative way. And 30 years ago, we had no problems doing that. Now we struggle to do that. And we wanted to find ways to do that. So that's what the goal of the committee was to look at that issue, create a pilot program that we could show to New Hampshire, the insurers, the world, whatever, that this can be done in a cost-effective manner, and I will underline cost-effective. We met 10 times. I was really excited with our group. You never know what you're going to get. There were 5 of us legislators, which I knew they were going to be there. Representative McKay, Representative Merchant, myself, Representative Lundgren, Senator Chanley, and probably missing somebody. But anyways, Representative Calabro. We met, we achieved a quorum at every meeting, and that wasn't the best part of this. The best part was the stakeholders who showed up for every meeting. We had a very unusual group of people that actually communicated with each other. We had insurers together, patient advocates together, representatives from virtually every type of modality. And everybody was really interested in solving this problem. I think the one group of people that interested me the most that showed up to every meeting were the people from hospice and palliative care, who I never anticipated as this being a need for them. And they actually helped guide us to solve our problem, because hospice in our country provides a bundled, comprehensive, integrative way of managing pain and symptoms at end of life. And what we discovered was we're really good at treating people when they're dying. We're not so good at treating them when they're living. And they informed us that there's 2 parts to hospice and palliative care. That's the hospice, the palliative care part. Those are the people that aren't going to die tomorrow. They may live years with their problems, and they found out that they have the same problems that we have in pain management in general, is they don't have access to these services in an integrative, bundled way. So they showed us the way, and we want to follow it. So that's basically what we did last year. Was we wanted to research the field, see what everybody's saying. We brought in speakers from all over the country. We were honored to be added to a nationwide consortium of comprehensive integrative pain providers, which actually we start meeting in a month. That was step one, and we pretty much completed that. The next step is figuring out how we're going to make this thing real. And there were 5 steps to that. Number 1 is, where are we going to do it, which we think we've already solved. Who's going to do it, which we have to work on. How we're going to pay for it, which we're getting steps towards doing that. How we're going to collect the data on all this thing, and what's our focus group going to be, because I wanted this to be more broad, but it's turning out that that's not going to be the case. So 3 of those 5 things we pretty much already solved. The next phase that we want to do through next year is actually to work on those, and then the third thing is obviously to make the thing real and exist, and we pretty much think we already have 2 sites to do that. So at this point, all I'm asking you to do is to support the bill from last year, extend our commission for another year, and then hopefully by this time next year, we'll be able to give you good news that this thing is actually working. And I will tell you, the entire country is watching what we're doing, because this is a very unique model. So I'm open to any questions.
Any questions? Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions. Why are you asking for an extension of only 1 year? Why not multiple years? And if we ever do see, like you said, that this commission is working, will it then be multiple years?
That's a great question, and if I had my way, I would have extended it for 3 years, which probably should have done. We decided to just do it this way, but I think your idea is a good idea. One thing you'll be interested in is, one of the things that we realized, there's a big difference between rural and urban health. You're in a rural environment, last I checked. You haven't had a big city grow up recently, right? No. So we felt that we needed 2 separate models, because they're very different. So there's going to be a rural and an urban component to what we do. And I thought that was one of the neatest things that came out of this so far.
Representative Wendy Thomas.
Thank you, Mr. Chair, and thank you for taking my question. You know this is going to be asked by me. Have you considered, or are you considering the role of therapeutic cannabis in pain management?
I've been doing pain management now for almost 40 years. In that time frame, I have a very biblical perspective on this. The house of pain is a house with many rooms, and there's place for everyone. In the book that I wrote on pain care policy, there is a chapter on cannabis use and pain care. There's nothing that's going to be excluded. So thank you.
Representative Nadarappan, did I see your hand up a moment ago? I'm sorry. Any other questions? Seeing none. Okay, thank you.
Thank you.
That was quick. I have no pink cards. Does anyone wish to testify on this bill? That is really quick. Okay. I know, this is like a public works or a fish and game hearing. So if no one else wishes to testify on HB 1712, I'm going to close this public hearing. We can't proceed to the executive session until 10 a.m. as noticed. So we're going to be in recess for about 17 minutes. Jerry.
Representative Cannon, can I call a caucus quickly? Thank you.
Okay, welcome back. The Health and Human Services and Elderly Affairs. We are now in executive session. We have several bills that we're going to be taking up during the course of the morning and afternoon. A couple of our members are over in Commerce, one of each party, so we're balanced out. Representatives Cofalt and Merchant will be joining us later, but they are working on another bill, and where it's balanced out, one of each caucus, it's a mutual agreement. We are going to change the order up a little bit today in consideration of those members being, temporarily gone. So we're going to be working on the bill's notice, but we are going to be changing the order a bit. 1585, we are going to take up at 1 p.m. So we're going to start with HB 1712, which we just heard from Representative Nagel, and I'll recognize Representative Nagel for a motion.
We have a question. We're
Sure.
going to amend that as outlined to increase the life of the thing till 2027. We don't have the amendment yet.
Okay, have you put the request in?
Yeah, I just wrote
Do they
something.
think they're going to be able to get it to us today?
I don't know. I just sent it like now. Should I?
It's a pretty simple amendment.
I'd suggest we just wait till we get that amendment and then take it up when we do. Hopefully that'll be
Alright.
today.
Yeah,
That's a
I
simple
said I
amendment.
need it
Hopefully we
now.
can get it done.
Should I
Okay.
call them or?
I'll send them an email to just
Okay.
encourage their speed if they can. Thank you.
Okay, so again, where it's simple language, it's not going to be a big change. So, all right, so we'll revisit 1712. Moving on, HB 1010. I'll recognize Representative Mazur.
Thank you, Mr. Chair. I would like to move HB 1010 to interim study.
And I'll second that motion. Would you like to speak to your motion, Representative Mazur?
Yes, as we heard from Representative Cushman, who was not here today, but she has requested this be moved to interim study. As we saw at the hearing, there was a lot of interest in this subject, and it was very clear to myself and I know others that this isn't a very important subject, and more work and research should be done on it, and hoping that can be done in an interim study.
Thank you. Any other discussion? Representative Shapiro.
Yes, I would support interim study because I feel that I'm in favor of people having as many options, medical options as they can, as long as they're not hurting other people, even if it's risky. But I had a difficulty with the bill as it was written because it seems to take, on the one hand, the Commission on Certified Midwifery seems to have the ability to govern both the requirements and the scope of practice, and yet we were going to bypass them and do it in a legislative bill. So I think that perhaps there's something that can be done to make the bill better that wouldn't do that and encourage more choice. So I would support interim study.
Okay, thank you. Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking, oh, never mind. Sorry. That's called a knee jerk. It's early. I support interim study as well. I will always have problems with these shortcut scope of practice bills. I think that there's a lot of issues with this bill. I could never support it as written, but I think that it certainly warrants discussion.
Okay. Any other discussion? Seeing none, I'll ask the clerk to call the roll. Motion is interim study on HB 1010.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Cofalt, not here. Representative Lewicki,
Yes.
is that a good pronunciation? Okay. Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yes. Representative Polozov,
Yes.
Representative Thomas, I'm sorry, Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant, Representative Harriet Gathright.
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald.
Yes,
18-0 and 2 not here.
okay,
I'd move consent.
okay, if there's no objection, we'll put that on the consent calendar. Okay, next up is HB 60,
I'll do this one so you can make a motion.
oh, okay.
Next up is House Bill 1638 FN relative to requiring case reviews and remedial measures for any Department of Health and Human Services employee who improperly performs their job. Do I have a motion?
I move ITL.
Is there a second? Okay, Representative Nattarath. Thank you. So would you like to speak to your motion?
Yes, thank you, Madam Chairman. I want to thank the sponsor of this bill for bringing it forward. Accountability in any profession, and particularly any kind of public office, is critically important. I particularly have I have a particular insight into the Department of Health and Human Services. I was there for 23 years as an investigator, as a senior investigator for the department. I did a lot of internal investigations of employees. I witnessed a lot of personnel actions. I'm aware of a lot of personnel actions, and as the department pointed out, they have a good handle on holding people accountable and disciplining them as necessary. So while I applaud the intent of the bill, I don't think it's necessary, and for that reason, I'm moving ITL.
Thank you. Would you like to speak to your motion? No need. Is there anybody else who'd like to speak? Seeing none, I'd ask the clerk to call the roll when he's ready. No. When I checked with the clerk's office, it's better not to hold the gavel when making a
Oh,
motion.
that's fine. Representative Nutter-Upham seconded, right? Yeah. Yeah, good point.
Representative Leon,
Yes.
Representative Bohm,
Yeah.
Representative Bill King, yes. Representative Kofal, Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel.
Yeah.
Representative Polozov,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
I'm sorry, yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter-Upham.
Yeah.
Representative Shapiro,
Yes.
Representative Merchant, Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald.
Yes.
18-0 and 2 not voting.
There's no objection. We will put that on consent. Or maybe that's something
Yes,
you should,
sorry.
I'm sorry.
And without objection, we'll put that on consent and then I'll hand it back over to the regular chairman.
Procedure is everything. Okay, thank you, Representative Leon. Moving on, next up is HB 1663, and we'll reverse roles, and I'll recognize Representative Leon for a motion.
Thank you, Mr. Chairman. I'd like to move interim study on House Bill 1663.
Is there a second?
Second.
Representative Nagel seconds. Would you like to speak to your motion?
Yes, thank you, Mr. Chairman. This was a bipartisan by-chamber bill that had sponsorship of both Democrats and Republicans in both the House and the Senate. There is absolutely important work to be done with this. However, it needs more time and attention than we can give before the deadline reaches us. Because we had heard such wonderful testimony and we want to make sure that we're able to make sure that our laws are appropriately protective but not overly burdensome. I would ask the committee to support an interim study on this bill so that we cannot lose all the important testimony that we received in that hearing and we can get some good work done.
Any other discussion? Representative Palmer.
Yes, I'm glad you're moving for interim study because my concern was what was going to happen being a border doctor. The difficulty of maybe getting records from New Hampshire into Vermont where I work. So hopefully that'll be one of the things that gets worked out.
Thank you. I'll put that in the committee report as well as one of the necessary goals.
Other discussion? Seeing none, okay. I'll ask the clerk to call the roll. The motion is interim study on HB 1663 FM.
Representative Leon,
Yes.
Representative Bohm,
Yeah.
Representative Bill King, yes. Representative Jim Kofal. Representative Lewicki,
Yes.
Representative Seth King.
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant. Not here. Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
Representative McDonald.
I'm sorry. Yes.
18, 0, and 2 not voting.
There's no objection. We will put that on consent. One bill that we also had noticed for today is HB 1300. We had we decided to continue that until March 20th, but I understand there might be some discussion on that. Representative Leon?
Yes, and thank you for that purpose. I'll move an interim study just so that we can officially be able to discuss this bill for a few minutes. Just as our colleagues are over in Commerce, and we can sort of address the approach that I'd like to take on the bill, if there's anybody who'd be willing to second that.
Representative Belasov seconds.
Thank you. Thank you, Mr.
Is it your
Speaker.
intention just for the purposes of discussion, but not an actual vote?
Correct.
Okay.
Because in executive session, we can't just sit and talk on a bill unless there's a motion on the table. So I will be withdrawing that afterwards. I think that this bill is very important, especially because New Hampshire's right to try law was passed before there was federal legislation to allow it. There are conflicts between the two, and there would be new conflicts created with the language of the bill. And those conflicts between what we would ask of companies to provide their therapeutics and what they're required to do by the federal government to be able to continue selling those therapeutics around or continue developing those therapeutics. When they're in conflict, that's going to limit any access that we have in the state. So we have both the investigational drugs that are allowed under compassionate use, and there's other programs as well. I believe that it's absolutely critical to make sure that if a company is not able to open up a clinical trial site for a patient who where it would be where there would be appropriate compassionate use for that drug, that we provide a pathway so that the long and rigorous process of opening a single patient clinical trial site is not required in order to allow patients to have this access. I believe that it's also quite important that we point this language to the bill that was passed last term about off-label drug use. Because if a drug is already approved for a use, but a physician is concerned about that use off-label in a terminal patient, we must make sure that this language would point them to that, because as long as there is informed consent documented, the medical boards are prohibited from taking action simply based upon the off-label status of that drug. I do think that it is important, and I'll be speaking with the medical board just to understand if there's anything else that would need to be done. Most likely, I would look to have the language to have the medical board draft any rules necessary in order to provide appropriate safety and protection for both the doctor and the patient, while maximizing availability to any therapeutics that would offer a chance at life extension or potentially cure for any of these patients. So I think it's an absolutely critical bill. I'm just worried that the reason why it wasn't working so well with our existing laws because of the conflicts, and I think that this would create some additional conflicts. So this is one of those ones that now that a couple other things are done, I can sort of stick my nose to the grindstone in the next week or so. I'll make sure that it remains germane so that we don't run into that issue. and hopefully be able to do something, because the last thing we want to do is have bureaucrats and red tape get in the way of a patient and doctor who want to try and extend or save somebody's life who's terminal.
Representative Shapiro.
Yes, thank you. Thank you, Mr. Chair. And I don't know if this is a question or a statement, but this bill is really important, I think. And I think, once again, people should have as much choice as possible, as long as it's not, doesn't endanger somebody else. I didn't really understand why the requirements for consent seem to be increased in this bill, and in my cursory reading made it more onerous to consent. I think there had to be 2 people, and it had to be notarized, I think. So I hope that'll be looked into too, because I don't know why the consent should be more onerous for this than for other things.
I would tend to agree. We actually have the prime sponsor of the bill filling in with us today, so I don't know if it would be appropriate to see if he can give us any insight on why he made it a little more onerous on the consent side.
Representative Lewicki.
Thank you, Mr. Chairman. The reason for doing that is that when people are in a hospital environment, they are subject to coercion. And medical people, typically, we get groupthink from the medical personnel. I'm certainly willing to revise it in some way, but I think it's very important that the witnesses, to the informed consent, yet that the informed consent truly be voluntary rather than subject to medical personnel knowing what's right and not allowing the patient to do what the patient actually wants.
Any other discussion? Representative Leon.
Thank you, Mr. Chairman. I think that actually, I'm wondering if that might be something that we can tease out, where when the patient is requesting access to it, we keep the same streamlined, but if the provider chooses to offer something that's like this, that then maybe we have the Board of Medicine or somebody else give us some rules around how to appropriately ensure that there is consent when you are bringing somebody in, when you're offering something that's not currently available. Would pursuing that path resolve those concerns for you? Thank you.
Other discussion? Representative Thomas.
Thank you, Mr. Chair. I just have a question regarding the bill, so I'm going to ask you. When my mom was in hospice, once she got on perpetual morphine, they said she could no longer make any legal decisions, and so my brother had to step in as the authority. Is that a concern here? Does that come into play at all?
I'm not really sure. It's not something that I had considered. I think that, having a family member be a witness to the informed consent would certainly be appropriate. And, whether a patient, obviously if a patient is effectively stoned, they can't truly give informed consent. Well, a family member could certainly assist. I know I've been through a similar situation with my sister, and who did not have any kind of durable power of attorney. And for 5 years, it was a mess.
Other discussion? Representative Leon.
Thank you, Mr. Chairman. So there's a little known law that we passed 3 years ago that allows for surrogacy, where if there's not somebody who's assigned, that they're able to go through a chain of command. The question would be if you would feel comfortable handing over that responsibility fully to somebody who is clearly somebody who's been named by the person should be able to make those decisions. My question would be if somebody who's a surrogate, so not officially named, but basically a descending order of next of kin would do that, or if that perhaps at that point the person is probably so close to it, maybe we shouldn't be experimenting or trying to play God. I'm just curious what your insight would be there.
I think we could discuss this offline. One of the situations, and this is subjective, with my sister was that she would get off her medications and she would be incapable of making decisions. When she got back on the medications, she did resume being able to work it. And I just think, I'm not sure we can hash this out right now, right here.
Thank you.
Other discussion?
Actually,
Seeing none,
Mr. Chairman, may I withdraw my motion for interim study, please?
you may.
And I'm withdrawing too.
Okay, so, at this point, we've had the motion withdrawn on 1300. We'll continue it to March 20th. And,
We can probably do this one. I can make the motion.
next up, we'll take up HB 1568 FN, Representative Leon.
Thank you, Mr. Chairman. I'd move interim study on House Bill 1568 relative to Medicaid reimbursement for non-transport emergency medical services bill calls.
Okay, is there a second?
And I
Representative Palazzo? Representative Palazzo seconds. Representative Leon, do you wish to speak to your motion?
Yes, thank you, Mr. Chairman. This is a complicated and complex bill that I'm not sure if should really have come to Health and Human Services, but probably should have gone to Commerce, because I heard quite a few discussions about this sort of billing in that committee. If the discussion can help clarify things for me here, then I may be interested in another motion. But right now, I truly don't understand exactly where those costs are going to go, exactly who's going to be liable, how this would. I recognize that there could be some benefit to those people, the towns and other ambulance services, but there's going to be an offsetting cost as well. And I truly don't have enough information to pass the bill as it stands, but I think that it's too valuable to kill. So that's why I've made the motion of interim study.
Other discussion? Seeing none. Representative Shapiro.
Yes, I will vote against interim study. I think this is I think I agree with the representative that it probably should have come to Commerce instead of to our committee. But I think that we did get a fair amount of explanation, and the intent of this bill is to have Medicaid reimbursement for when emergency services goes out to a home or to anywhere and provide services, but doesn't need to transport someone to a hospital. And right now, emergency services are eating those costs. We know there's an issue with emergency services in the state, keeping them robust and keeping them functioning. And so I think that we should be doing what we can to support their functioning by having Medicaid reimbursement, which will not be enough, of course, because Medicaid reimbursement is low. But it will be doing something towards ensuring the medical infrastructure for our state. So I would vote against interim study. I would urge people to vote against interim study so that we could pass this along. And maybe it would go to Commerce in the Senate. Is that possible?
Anything's possible. It's up to the Senate President.
Okay. Anyway, that is my thoughts.
Okay. Representative Nagel.
Thank you, Mr. Chairman. There's another committee involved in this, and that's finance. I mean, no, not at all? Really?
No, it's too late. It's not a second committee bill.
Wow,
The second committee bills were weeks ago.
because this is an expensive bill potentially. Wow.
Other discussion, Representative Tellez.
Yes, thank you. I appreciate the comments. I think it's really expensive, or it will be even more expensive if our emergency service providers go out of business, which I think is a concern that was raised. I'm also very impressed by the showing that we have, that I'm assuming is related to this interest, given the insignias that I see on people's clothes, because I can't tell who all the lobbyists are. So I heard loud and clearly that there's a real ask for this, and it makes sense that, we don't have to figure out the details of how to make it happen. We just have to provide the guidance that it needs to get figured out. And I would be also in favor of trying to make sure we pass this, and we'll vote against interim study.
Other discussion, Representative Palmer.
Yes, I'm also against interim study. Increasingly, I've ended up taking care of patients in our small critical access hospital that needed to be in a tertiary care center for longer than I would like, because we could just not get transport. And so anything that will improve the ability of ambulance services to provide service and staff appropriately, I think we need to move in that direction. And I think the other thing is from another point of view, it's really not fair for an ambulance service to go out to somebody's house, pick them up, put them back in bed, and then drive back and not get paid anything for that. So.
Okay, thank you. Representative Nutter Upham.
I also agree that those kinds of services should be covered, as I've hit an age group where more and more of my family members are needing quick assistance, but not admission into a hospital. So, and of course, in Nashua, it's only a couple miles to get there from an ambulance. So I'm in favor of not interim study, but ought to pass and let others work out the details.
Representative Shapiro.
Thank you, Mr. Chairman. I understand that Representative Leon's idea of sending this to interim study is not because she thinks it's a bad idea, but just because that the financial aspect of it has not been fully examined. And this is really a question of the chair or anybody else who might know. If we pass this and put in our report that we think it should go to finance in the Senate, might that have an influence, and might they be able to examine the financial dimensions, and then it would come back to the House, obviously.
Well, that's a possibility, but there's no way of knowing what, as we know, the other body is a pretty independent group of people. So I wouldn't want to try to.
Well, we
second-guess.
can suggest.
We can suggest, yes. Other discussion, Representative Leon.
Thank you, Mr. Chairman. I think that this discussion has both made me realize the importance and also the magnitude of this. Recognizing that there's probably people who aren't calling for this now because they've had somebody who's fallen and that they need the assistance to get up. I think that it's very important, but also if we're under reimbursing through Medicaid, we may actually be causing more of a problem too for these providers. This is not a good situation to be in. And my concern is just that there's so much that still remains unknown on this. There's so many bills this year that it's hard to count on the Senate to do the hard work that we haven't been able to figure out as well. So that's just my large concern here.
Representative Nagel.
Question and a comment and a question. It surprised me that this wasn't reimbursed now. That really surprised me. But having seen a lot of visits, that there's no transport involved. But my other question is, if this goes to interim study, it still stays in our committee, correct? It doesn't go to finance at that point. Am I correct?
That would be correct, but I know that we have had, with interim studies, have people come in, not officially, but have people from other committees that can come and discuss and help us better understand what the implications are, especially because some of these would probably then, because it would be drafting another bill, we'd probably want to look at the expertise of people who could do that so that we can introduce something and perhaps have the correct sponsors on that one so that it might go to the right committee. I know that this year has just been so difficult with everything. We're doing the best we can all around. But I just think that passing it and hoping that somebody else will do the work for us is not the right way to go about legislative business.
Okay. Ms. Dyer, as always, has been very helpful. Apparently, Commerce does not deal with Medicaid at all. So that's which I guess in retrospect makes sense. But she's offered to do some research on this and enable us to make a better judgment if we want to continue this to March 20th. Or we would have to withdraw that motion.
I'd be willing to withdraw that motion. I think that it's important. We just need to make sure that we can understand what we're actually doing with this. So I'd be willing to withdraw.
Representative Shapiro.
I wonder if part of the research that could be done would be to get some kind of financial note about the implications of passing this. So we could at least have an idea of what we're working with.
Representative Tejas.
Can we ask Mr. Williams if there's any information he could share about this?
Sure. Attorney Williams? That's- Okay, thank you. Christina, is that something, is any of the financial stuff, anything that you might be able to check out for us or pry loose for us or? Okay, thank you. Representative Tejas.
Yeah, I think I have one additional comment. I mean, this is a public good that we don't think about until we need it. So I kind of feel like it doesn't really matter what the finances are. It's a need. New Hampshire's a rural state. We have all these critical access hospitals that have closed. We're hearing that emergency providers show up, provide care that is needed, and if patients are lucky enough to not have to be transported, that's great. But if that's ending up being sort of a stopgap care provision that people need, I don't understand why we're even debating it. Like, it needs to get figured out. We're not going to figure it out no matter what the bill is. This is a policy decision. Do we believe that this is something that should be supported? Because we've heard over and over that this is causing them financial risk. And, you know, when it's your mother that needs the ambulance, you're going to be pretty upset if there's no one there to show up.
Other discussions? Representative Leon, you,
I just wanted to just scan through the bill text again real quick. So looking at the bill text again, it's not Medicare, it's just Medicaid. So we do have some elderly citizens who are on both, but Medicaid is more on a younger time because we have the people who are on Medicaid. Obviously, there is overlap, and obviously we do have quite a few people who perhaps do have needs to be able to do some of this as well. But this is just Medicaid. It's not Medicare. So a lot of our elderly family members are on the Medicare as opposed to the Medicaid, and that's a federal issue. So this is a smaller wedge. It does look like there was a fiscal note that has been shown, but it says that it's over $1 million general, over $1 million federal, and they don't know how much it will be. So because there's just a lot of uncertainty. So I had moved to withdraw my motion of interim study so we can get some more information ahead of our meeting on March 20th.
Yes, I'm withdrawing my second.
okay, so we will continue 1568 FN to March 20th. Just for everyone's awareness, we're not planning to meet next week, so we'll be dealing with any bills after today on March 20th, which is the final day we can deal with them. All right. Okay, again, we're to accommodate the two members of the committee who are trying to help out on an important issue in commerce. We're trying to, jockey around a little bit here. Representative Shapiro, did you want to talk about 1028 this time?
Yes.
And everybody should have an amendment, 0963H that Representative Shapiro distributed earlier.
So,
Would you like to move the amendment?
yes, I will move that we adopt Amendment 0963 to House Bill 1028.
Is there a second? Representative Nagel seconds. Representative Shapiro, would you like to speak to your motion?
Yes, so this is a bill that was brought forth, I don't remember the sponsor, but it was obviously brought forth by advocates for the developmental disabilities community who felt that the statute that was currently in place, including the definition of mental illness, which I think is, beyond this bill, is a very flawed definition, but that the definition said that people with intellectual disabilities, that the definition of mental illness did not include people with intellectual disabilities if it was primarily caused by developmental disabilities. And so whatever the wording is, it seems to be that the reality is that sometimes people with intellectual disabilities or developmental disabilities are sometimes denied mental health care by the state system, by New Hampshire Hospital, by the mental health centers, because they are simply told that this is a developmental issue, not a mental illness issue. And so this is an attempt, the bill in itself is an attempt to make it so that people with co-occurring disorders, whether they have an intellectual disability or not, if they have a mental illness, that they will be eligible for treatment through the state system of mental health. So the initial bill, just going to get the bill. The initial bill did two things. On line 18 and 19 and 20, it said an individual shall not be determined ineligible for services under this chapter on the basis of co-occurrence of mental illness and an intellectual or developmental disability. And the amendment that we're bringing today leaves that in. The initial bill also takes out in Roman numeral 10, Part B, it removes intellectual disability. And in working with Representative Nagel, we both felt that that did not make sense because it was initially put in there because you wanted to be able to discern the difference between someone who had an intellectual disability and mental illness. We didn't want people to assume that everyone who had a disability was also mentally ill. So I think it was initially put in there as a protection for people, and it didn't make sense for us to take it out. However, people, disability advocates felt like this was often used to create an obstacle to people getting mental health care. So my amendment changes on line 8 in the amendment. It says instead of primarily caused by epilepsy, intellectual disability, intoxication, etc., it says it does not include impairment solely caused. And we think that that is a small change, but one that clarifies that we're talking about co-occurring disorders, and we're saying that people should be eligible for mental health care unless the behavior or symptoms shown are solely caused by that disability. So it's a small change. I think it satisfies some of the people who brought the bill in the first place. I think it clarifies things, and I would urge you to adopt the amendment.
Representative Nagel, do you want to speak to your motion also?
Sure. This was a lesson in legislation for me. I've never been involved in so much discussion based on the strikeout of a single word, but it was really important and impressive. And I have to say, just viscerally, just seeing that strikeout from the minute I saw it really bothered me a lot. Part of it is because I have a son with an intellectual disability. I have a cousin with an intellectual disability. My wife would say she has a husband with an intellectual disability. But anyway, so
She'll have to sign.
you know, I think the reason why that's excluded, because historically people looked at intellectual disability and mental illness as the same thing. And I think it was important that that be excluded. I've dealt with people with disabilities my entire life. And one of my papers that I wrote back in the 1990s was on post-stroke depression. And we were looking at the neurophysiology of that. Is this a separate thing or reactive thing? Is it from the neurophysiology of the stroke itself, whatever? But we always looked at them as two separate things, that we treat the stroke here. We do not deny your right to have full treatment of your depression as a separate thing. And so to me, it was important that we acknowledge the comorbidity, but that they're not the same thing. And it seemed to me when you did that strikeout, you're removing it, that distinction. With that said, it seemed to me that everything that they wanted to accomplish with this bill was in the last paragraph, and I thought that was really important. And I just want to make one public statement. It really bothered me that this bill is even necessary. I don't understand how you could deny people access to care for depression and disability is so common, or other things that they really deserve. They're worthy of their own distinction, and they need to be addressed as such. So I would encourage you to support this amendment as well. A lot of discussion.
Representative Shapiro.
Yes, I just, in case I wasn't clear enough, the initial bill struck out intellectual disability. The amendment puts it back in, but says solely caused by it. And I do want to make one comment. There was a lot of very compelling testimony. Unfortunately, I think that even with this bill, it may reduce one obstacle, but certainly people with intellectual disabilities or developmental disabilities aren't the only people waiting on long lists to get services. We know that the emergency room boarding problem is a problem. Maybe it's more of a problem for people with developmental disabilities, but it's a problem for children. It's a problem for adults, and this is one thing that we can do to maybe ease the situation for some people, but I don't think we should fool ourselves into thinking it's going to solve the whole problem.
Representative Leon.
Thank you, Mr. Chairman. I think that this is a really interesting and potentially good way to go. It's something that I probably would want to just sort of have a couple minutes to think about. I'm thinking it looks like we may be getting our friends back from from Commerce, and I know that we've been trying to manage what we're doing with all of that too. So I didn't know if it'd be possible for us maybe to have a caucus just to be able to discuss it and just figure out time frame wise as well, because I think that this probably is an important one to make sure that everybody can be on the same page about, because this definition of mental illness is pretty significant. So either if we did it that way, or if we withdrew it and got back to 1712, because I've heard back from OLS that we can't actually change that date because it's in chapter law, not in statutes. So I didn't know if it would make sense to withdraw that and maybe go through 1712 and then take a break in which we could caucus, and then everybody could expect how much time they could have to use the facilities and whatnot before we're there. Although then again, we have everybody back too. So I'm not sure what the best way to go forward is. I've just been trying to work on the fly here today and accommodate everything. But I would like to have a chance to sort of wrap my head around this change from primarily to solely.
Yeah, well, when we can, as I understand it, even though it's on the floor, I think we can continue it till, we don't need to withdraw it. We're going to continue it today, I don't believe.
I'm not sure exactly what the best process. I don't know if maybe we just want to take a caucus until 5 or 10 after, just to give people a chance to use the restroom and whatnot and discuss it a little bit. And we also were trying to make sure that we had time to get you guys back in, because we've done just about as much business as we could without you.
Thank you.
Thank you.
All right, so, okay, why don't we do that then? Why don't we recess for, what are you proposing, 20 minutes?
Probably until 11:10.
All right, 20 minutes, 22 minutes. All right, we'll take a relatively brief recess. Republicans will be having a caucus in the committee office, and anyone else who needs to take care of anything in the meantime, please feel free to do so. So we'll be at recess for 20 minutes. Okay, I'd like to reopen the executive session. And we were discussing HB 1028 before we recessed. So I'd like to return to that. A motion is on the floor, I believe, for amendment 0963H. Is there any other discussion? Seeing none, the clerk is ready. I'll ask him to call the roll.
We're on Bill 1028,
Uh,
Mr. Chair.
HB 1028 as an amendment, you should have a copy of 0963H, authored by Representative Shapiro,
Thank you.
and co-authored by Representative Nagel. Okay, all right, okay. Okay, Mr. Clark.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King.
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20 to 0.
Okay, do I have a motion on HB 1028 as the main motion? Representative Shapiro.
Yes, I move, ought to pass on House Bill 1028 as amended by.
0963H.
0963.
Okay, Representative McKay seconds. Any discussion on the main motion of ought to pass as amended for HB 1028? Seeing none, the clerk is ready.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Harriet Gathright, Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20 to 0.
Okay, if there's no objection, we will put that on the consent calendar. Okay, now let's revisit HB 1712. Representative Land, you said that we cannot get an amendment on that, is that correct?
Yes, correct. Because this is not a statutory study committee, we can't extend it past November of the even numbered year.
I knew there was a good reason.
Okay, with that, Representative Nagel, do you want to make a motion?
Make a motion ought to pass on HB 1712.
And I will second that motion. Representative Nutter Upham. Oh, you will say, okay, that's fine. That's even better. Representative Nagel, do you want to speak to your motion? Okay, okay. Any discussion on the motion? Seeing none, a motion is ought to pass on HB 1712, when the clerk is ready.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham. Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Harriet Gathright. Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
20-0.
Okay, there is no objection. We will put that on the consent calendar. Next up is HB 1280, Representative Leon.
Thank you, Mr. Chairman. I move ought to pass on House Bill 1280.
Is there a second? I can second, well, Representative Missouri seconds. Representative Leon, do you wish to speak to your motion?
Yes, thank you, Mr. Chairman. This is a bill which would take basically the informed consent guidelines that are already in the AMA requirements and put it into statute. One of the areas that we have challenges around is enforceability. Whether that's swearing somebody in to testify when there's no enforceability, if you can't do anything, if somebody tells you something that's not the truth, whether it is any of our other statutes that may or may not be followed. But it's one thing when you have, if by putting this into the law, there would be another reason to make sure that any of the providers who aren't following through on informed consent are actually doing this. This is one of those important areas where there is a distinction between in provider-based informed consent and patient-based informed consent. And this makes sure that the patients have to be part of the discussion. That's been a bit of a gray area in New Hampshire, where some people say that it's only based off of what a doctor wants you to know. But that leaves a lot of liability for our providers. If we get this into statute and they're clearly following not only AMA guidelines for physicians, but also that it's in the state law, that provides a lot of protection for them if somebody says that the correct informed consent was not followed, because it just provides more clarity by putting there. I know some people would want to expand this to other provider types as well, and I recognize that, but you can't really just take the AMA guidelines for physicians and then give that to everybody else. That would need to take a little bit more nuanced look, and that's something that I know I personally am interested in doing over time, because informed consent is vital. You can't have a patient be an active participant in their healthcare and their recovery if they truly don't know what they're doing and why. And so I'd like to continue moving towards this more outlined, more collaborative process so that we can make sure that providers and patients are working together to improve health.
Other discussion? Representative Nagel.
Thank you, Mr. Chairman. I appreciate everything that you've done on this bill and all the discussions that it's led to. And I wear two very different hats on this bill. The one hat is a doctor who's got way too many people in my exam room right now telling me what to do, and I don't even know who I'm treating anymore, which is kind of really sad statement. And it just seems to me that this is yet another intrusion on that relationship, and especially considering everything in this bill already exists. I already have to do all this. I have to take a class every year that reinforces I got to do all this. At the same point, we are witnessing a corporate takeover of healthcare before our very eyes, and I'm not sure that this is so much directed as me, the doctor, and my patient as I am at the corporate provider. So the one side of me is really violently opposed to this bill. The other side of me is violently in support of this bill, which means that I guess I'm schizophrenic. So I'm probably going to not support it, but I really appreciate it. And what I really like what you said, Representative, was I think this does need to lead to a lot broader discussion on a lot of levels, and I really appreciate.
Other discussion? Representative Merchant.
Thank you, Mr. Chair. I'm of the mindset, I think also Representative Nagel, the intent of this bill I truly support. I think I'm really concerned about how it's going to impact the medical community and also the care for patients. We have physicians that are today buried in paperwork, and my concern is that we're adding another layer of paperwork to it. So I don't know what impact this is going to have on the ability of the provider to have enough time to see the patient versus taking care of all the paperwork. So I'd rather go to interim study and talk about this. I think it has a lot of merits, but I'd like to be sure what we're doing actually has been thought through, and we hear from the medical community how this may impact them. So that's kind of where I'm coming down. but I do want to say thank you to the representative for bringing it to our attention.
Representative Nagel.
Yeah, I just wanted to clarify what you just said. I don't really think it's gonna add to the paperwork at all. I mean, when I started out, you had talked about patient-centered informed consents. That's what I created. I've written at least 30 of them. And now I'm told I'm not allowed to do that, that the risk management people have to write the informed consent for me. And so when it was funny, after we had our hearing on this, I went and looked at the informed consent patients for signing in the OR before I'm about to do a procedure. And it was a patient I'd known for a long time. And I looked at her and I said, "Did you read this?" And she goes, "No." And I go, "You know what? Neither have I. Let's read it together." When we read it, I go, "I'm not signing this. Are you?" And she goes, "No." And it really actually led to a big discussion of trying to take this back from the risk management people to do exactly what you just said. So that's why this is really important. But as far as paper, it is so easy now. I just sign, they sign, nobody even looks at it. And I think that's really tragic.
Yeah.
Other discussion? Representative Palmer.
So I think that the concern I have is a lot of what Dr. Nagel and I mean, Representative Nagel and Representative Merchant said, which is, it's clearly a very important issue. But for example, on line 15, where it says that it says the physician shall include information about the burdens, risks, and expected benefits of all options, including foregoing treatment. And so I am concerned that, well, who's deciding that, and how do I document that every time I make a decision about a patient? So for example, I mean, I might be just simply choosing an antibiotic for a patient, but now do I have to document exactly why I picked that one? I mean, usually there's some indication of why, because it's the correct one for that diagnosis. But again, I guess what I'm saying is I would support what Representative Merchant said, which would be interim study, to make sure that we're not creating a monster that's going to make, you know, my life and everybody else's really difficult at a time when we can't recruit anybody. I'm hoping to retire at the end of this year, but I'm probably not going to be able to. And one of the reasons is the paperwork burden, and I don't want to increase it. I want to make sure that this, you know, if this could be done in a way where we're streamlining things so that it's, you know, it's really clear exactly what needs to be there, that would be great. But I'm not, right now I'm uncomfortable.
Representative Merchant.
Thank you for that, Representative Palmer. As an option to interim study, this is not an early bill, correct?
It is not.
So if Representative Lyon's willing to sit down with myself and maybe some other folks and hammer out something that's more logical, that based upon the medical community and so forth, I think that may be another way to get to the same thing without holding it up completely this legislative cycle.
Representative Lyon.
That would work for me. We do still have another 2 weeks. I think that just, we've worked well together sort of offline. I don't think we need a subcommittee, so we can just sort of discuss this.
We can, but I encourage us to have both Representative Nagel and Representative Palmer part of that conversation because they come from the medical community more than I do. I think the input from them would be truly valuable.
Representative Nagel.
I'm sorry that Representative Cushman's not here to answer this, but my understanding, and I did look through the AMA guide, this is directly from the AMA guides. There's nothing in here that we're not supposed to already be doing. I mean, the way I do it, maybe I should tell everybody else how to do this, but I create an informed consent that's part of my entire process. So when I meet with the person, tell them what I want to do, what I don't want to do, that informed, what I created was part of that whole discussion. So when it comes time to sign it, they already know what they're signing because we already talked about it. I don't think that that happens, but this is what I'm already supposed to do. There's nothing new here. And 40 years ago, my dad informed me the most common reason doctors are sued is failure to get informed consent. And so 40 years ago, he taught me to do everything that's in this bill. And that's why I struggle with voting against it. But it's part of what I have to do.
Representative Merchant.
Thank you, Mr. Chair. As I listen to what you're saying, Representative Nagel, if it's already in the AMA guidelines, the challenge with guidelines are exactly that. They're guidelines, not statute or requirement. So maybe by simply making this bill saying that the physicians will follow AMA guidelines, will be sufficient, because at that point in time, it then requires them to follow the guidelines versus putting it actually in statute. I just throwing it out there.
Representative Kofal.
Thank you, Mr. Chairman. So I have concerns about that approach. I have concerns whenever we put something in statute that references an external organization whose standards could very well change. We are then, in essence, delegating legislative authority to an organization that is not only not elected by citizens of New Hampshire, they may not even be from New Hampshire at all. So I would urge caution in taking that approach.
Representative Nagel, did I see your hand up?
Yes, so yeah, I just wanted to say that what Representative Merchant said is already in rules. It's not in statute, but it is in rules. Yeah.
Representative Leon.
Thank you, Mr. Chairman, and thank you for all this conversation and this insight. I think that the difference between having the need to follow AMA guidelines and rules, that allows the medical board to look and say, well, actually what you're doing is consistent with where the AMA is headed. When I was a device analyst, we had the guidelines from all the different medical societies. And it's sort of the baseline to be able to have those guidelines. But sometimes something that was emerging and somebody that you were doing actually ended up contradicting the guidelines because there was emerging evidence, but it wasn't yet the fully adopted practice. And so that's why I think the idea of sort of airlifting one of these areas that is so crucial to this care, specifically out of a guideline that's already been vetted, and sort of freeze that in time and freeze that in statute and have it so that it's a shall instead of a may, I think makes sense in areas like this, especially ones where you see that it should be such a general action, something that we should be doing. If we're not able to get to an agreement on ought to pass today, I'd be happy to pull that back, withdraw that, and see what we can get to for the 20th, so that perhaps we can come out and have more of our bills on the consent calendar, as opposed to needing to debate them on the floor. If by spending a little bit more time, we could get there. So with that, I'll withdraw my motion.
Okay, Representative Mazur, did you second that? Okay. Are you withdrawing your second? Okay. That's just a question. All right, so the motion has been withdrawn, and we will continue that along with 1568 to March 20th. Okay.
Mr. Chairman, if I may?
Yes, Representative Merchant.
This will be not an official subcommittee. This will be an ad hoc committee,
Right.
so we can
This will be
communicate via
an
Zoom.
informal effort by.
Informal effort, right?
Yes.
So we can utilize the technology versus meeting in person, correct?
Sure.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. I'm not sure I understand this, but I hope that when there's further discussions, that the issue of, on page 1, line 24, where it talks about patients' rights, is that an addition to the patient's rights that already exist? Is it completely different patient's rights? And does it make sense to have patient's rights in more than one place? So I'm not really asking for anything right now, but I'm just hoping that that'll be part of the discussion.
That's actually a really important point. The Patient's Bill of Rights is not binding on providers. It's binding on facilities. So it wouldn't be appropriate to have this in the Patient's Bill of Rights, because that's about the facilities, not the provider
But
themselves.
maybe it shouldn't be called patient's rights. Maybe it should be.
If you can, I'd be happy to consider other words that you have, but the right to have informed consent, I think, is pretty fundamental. But I'd be happy to discuss that
Okay.
offline as our legislative
Okay.
friends in our ad hoc type way.
Okay,
Thank you.
I'll think about it. Thank you.
Any other discussion on HB 1280? All right, moving on. Next up is HB 1347. Representative Kofal, do you want to make a motion?
Yes, I move interim study on House Bill 1347.
Okay, and I'll second that. Would you like to speak to your motion?
Sure. So I think that this bill, by the sponsor's own admission, was not ready for prime time. It doesn't actually pertain, or it wasn't intended to pertain to the refugee resettlement program. There are things, it was not drafted to align with his intent. Having said that, I think we have all heard concerns about veterans who are being displaced from services, people who are who are not necessarily getting the services they need, not in New Hampshire, but we've heard stories from other states. So I think that there is a legitimate question that needs to be discussed and investigated, and so for that reason, I would move interim study.
Thank you. Other discussion? Seeing,
I was just gonna say that sounds very reasonable and I'll vote in favor of that.
okay, Representative Shapiro.
I agree that this would be an acceptable outcome, but I'm going to vote against it in hopes that it can be ITL'd. I think that, as was said by the previous speaker, the sponsor themselves said that the bill was poorly written and didn't align with his intent. And I would support interim study if the intent that was talked about was really a broad discussion about immigration and how immigration affects New Hampshire, both the incredible benefits it brings and the problems that it brings, and how we can look forward at making immigration work for New Hampshire. I just read in a business magazine this morning before I came that while the population of New Hampshire is increasing, that the population increase from 2010 to current, half of that population increase is from international immigration. And I think, so unfortunately to me, because I would like to defer to Representative Edwards, the prime sponsor, unfortunately to me, all the conversation after it was acknowledged that the bill was not as it should be, was about how to make sure that immigrants don't cut in line. And first of all, I don't think that happens in New Hampshire. Second of all, I think there are federal laws about, for example, for Medicaid, about whether people in certain categories of non-citizen status have to be given Medicaid, or have to be eligible, not have to be given, have to be eligible. So I think the discussion after the acknowledgement that this was not a well-written bill was all leading to a future bill that would be divisive in my mind. And so I would rather vote for ITL, but I understand if people would vote for interim study. And the discussion will be what it is if that happens.
Thank you. Other discussion? Seeing none? Okay, the motion is interim study on HB 1347. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Foam,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yes. Representative Polozov,
Yes.
Representative Cannon,
No.
Representative Thomas,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Nutter Upham,
Yes.
Representative Shapiro,
No.
Representative Merchant,
Yes.
Representative Harriet Gathright,
No.
Representative Palmer,
Yes.
Representative Tejas,
No.
and Representative McDonald.
Yes.
13-7.
Okay, Representative Shapiro or someone, is there gonna be a minority report on that? Okay. All right, thank you. Representative Shapiro, are you writing that one, or minority report, or? Okay, great, thank you. Okay. Next up is HB 1607. Representative Seth King, I know you have an amendment.
Thank you, Mr. Chair. Yes, I've handed out the amendment. Everybody should have a copy of it. I'd like to move that we adopt Amendment 2024-0591H. Ought to pass.
Okay, is there a second?
Second.
Motion's been made by Representative Seth King and seconded by Representative Merchant. Representative King, would you like to speak to your motion?
Yes, thank you. This is a very interesting part of the bill that we're going to be discussing here. And I just want to preface it by saying that I think honest people can disagree on this issue. And I totally understand where the people who disagree with me on this are coming from, and I don't blame them one bit. However, that being said, I'd like to still state the position I'm making. So to start off, this bill, I really see it as two parts. There is the first part, which allows for baby boxes and also increasing the number of days that an individual can drop off a baby at a baby box, for example, from 7 to 61 days, I believe. The second part of the bill is an added exclusionary clause that I think is just a bridge too far for me personally. There is already immunity in the current statute that allows for parents to drop off their baby and not have to fear prosecution for neglect in that way of dropping off the baby. But what this exclusionary clause would do is that if a parent, for example, were to drop off a baby that had been severely intentionally abused in ways that we can use our imagination, but I'm not going to say here, the evidence that the state would have of that abuse would be on that child, and it's likely that there would be no other way for law enforcement to get other evidence of the abuse. So the evidence is strictly on that child, and this exclusionary clause would tie the hands of law enforcement from being able to prosecute, or at least use the evidence found on the child in a prosecutorial manner. And I know people don't always like analogies as much as I do, but I love analogies. So I'm going to use an analogy here just to sort of, I think, help wrap our heads around what we're actually doing. I think many of us have heard of the moral conundrum. If you are a conductor on a train and you're going down the track and you can't stop, and you see 5 people tied to the track, but you have the option of, cranking the levers and switching to a track that only has 3 people tied to it. Which do you choose? And that might be easy if all else is being equal. But what happens if the 5 people are really elderly and the 3 people are babies? Or what if the 5 people are convicted convicts and the 3 are known heroes to the community? I mean, you could keep playing these games. The point is it's a very difficult conundrum, and people have debated these sorts of things for a long time. And I see that as what's happening in this exclusionary clause. We are deciding which babies we should save and which we should throw under the bus. And that's a very difficult decision. And I don't blame anybody for taking the opposite position I am. But what's happening here is that we are potentially letting, if this exclusionary clause stays, we're potentially letting intentional abusers get away with their crimes so that they can commit more crimes, in the hopes that by doing that there will be other parents who will feel more secure in dropping off their babies without fear of legal repercussions. And there's been a lot of talk about who those parents might be. A lot of parents, they're addicted to drugs and they just do not have the wherewithal to take care of their children. And after a few days of neglect, they come to their senses, thank God, that they need to drop off their baby. And unfortunately, there are concerns that law enforcement will then use that as evidence to go prosecute them for drug crimes. Okay, and I'm against that. I have been openly against the war on drugs my entire life, and I don't like the idea of that happening. However, the thought of a baby being in the care of a parent who is addicted to drugs and is not capable of taking care of their child, that's a bad thought. But it's not as bad as a child being in the care of somebody who is intentionally abusing children. That to me is a far worse thought. And once again, we're playing the conductor conundrum here. Ultimately, what it comes down to, I see it as this, and that is there's a bad guy here. Somebody is the bad guy. We are with baby boxes and allowing parents to drop their children off. That's a pretty sweet deal. But by adding this exclusionary clause, what we're doing is we're sweetening an already sweet deal. We're saying, not only can you be a terrible parent, but we're gonna just look away from prosecuting you for your misdeeds. And when we do that, when we shirk our law enforcement job, we become the bad guy. And the way I see it is that I would rather the parents be the bad guys as opposed to us being the bad guys by shirking our responsibility. And, well, I'm sure there will be other people that have some things to say, and I may have to chime in again. But ultimately, I'm not prepared to let the state be the bad guys. I think that, and the last thing I'll say is that when we fail to do our job, when law enforcement has their hands tied in this regard, it often will encourage more lawlessness. And I think that that's just an unintended consequence. I really do understand where the people are coming from that support the exclusionary clause, but I think there are going to be unintended consequences. We put that in there, and I, for one, cannot put my stamp of approval on that, so much so that I happen to like the rest of the bill, but if that exclusionary clause is in there, I will not be able to support the bill if it stays. So that's why I've offered an amendment that will help to get rid of that exclusionary clause. Thank you for listening to me for so long.
Representative Leon.
Thank you, Mr. Chairman, and thank you for that. And thank you, Representative Seth King, for following through on what you see as your moral obligation to reduce harm. I see this essentially as a death penalty bill. You have the potential that children who are not surrendered otherwise may be killed by their parents. And that's always a hard decision to figure out, where you are trying to potentially let somebody who is a monster not have appropriate punishment for them. If you look at my mind also went to those deep, dark places about what somebody may do. I was in a Girl Scout troop that had one of the first women prosecute somebody for DNA on hair. A judge in a lot of the ones that literally I know the people that are in the forensic files shows, and I watched too many of them. So monsters exist. But there's a lot of people that, because of circumstances, act like monsters as well. But if they were given a chance, they wouldn't be a monster. I'm not convinced that by having this but not having the exclusionary rule, you'd still have those monsters who may be serially abusing children still forfeiting those children. So I'm not sure that those children would be saved even by passing this without the exclusionary rule. But what I do know is that people who are on the wrong side of the law, they know what happens. They know through the grapevine what happens when somebody tries to do the right thing and then gets popped for something related to it. I'm worried that if we don't have this exclusionary law, we're having the death penalty for kids, for parents who are just so messed up that they're so afraid of what's going to happen that they kill their child instead of surrender them. And I recognize we may let some monsters get away with horrible things. But to me, the more run of the mill situation where somebody by circumstance acts like a monster is a lot more pressing and something that we have the ability to do something about. I appreciate where you're coming from. And I think that, and I apologize for not really crystallizing that I really see this as a death penalty situation before. I apologize for not discussing that with you before, because until you were discussing this, I didn't realize that really what we're doing is we're deciding when the death penalty is appropriate, because I see that that is the other option for a lot of these children that aren't surrendered. And to me, I appreciate the intent behind removing the exclusionary, but I really think that we need it in order to make sure that unfortunately, run of the mill parents who just can't take care of their kids, who are violating other laws, are more comfortable surrendering their child instead of destroying the evidence that is that child. So I have to vote against the amendment. If the amendment passes, I have to vote against the ought to pass as amended, because I think we have an opportunity to save lives and improve lives here. And I wish there was an easier answer, but I have to be opposed to removing that exclusionary rule.
Representative Merchant and then Representative Mazur.
And thank you, Mr. Chair. This is more of a procedural question than anything else. The current law has lines 27 through 28 in the law. I supported the amendment because there's a lot of concern on lines 29, 30, and on top of page 2, because it provided too much of a immunity to the parents. If we pass this amendment, are we therefore striking in the current law lines 27 and 28, or are we just striking 29 through the end?
Representative Leon.
Thank you, Mr. Chairman. That is an amendment to current law. So if we remove section 6, then the current law, which has those lines 27 and 28, would remain unchanged.
It does say section 4. Right, that's
just for the bill.
Yes, that removes the amendment to current law that is in section 4. So if we remove section 4, it's not deleting section RSA 132-A4 liability, which are those lines 27 through 28. If we dilute section 8, then that remains in law unchanged.
Thank you, because one of the concerns that I heard anyways, I think we all did, was the concern about lines 29, 30 and the top of page 2. And it gets back into the possibility of having a conflict as far as the ability for law enforcement. It was just a quagmire. And I think to Representative King is that it's one of those things that we need to really think through. In the way it's written right now, I think it's problematic. And law enforcement came and said they had concerns with it. The Department of Health and Human Services had concerns with it. A lot of people had concerns with that language that's in the bold. So by deleting that, I can move forward with the bill. I think the bill in line is appropriate, has a lot of merits to it. But I'd be willing to work with somebody to change the language that we can work on. But at this point in time, I can support the bill with the amendment.
Representative Mazur.
Thank you, Mr. Chair. I heard the assumption that placing a child in a safe haven box, means that the child is being grossly abused. That is an assumption. That's not always the case. A child can be placed in a safe haven box. The parent could could be struggling with taking care of that child and just can't do it anymore and has to give that baby up. It does not mean that that child has necessarily, sure, sometimes that would be the case, but it doesn't always mean that the child is being neglected or abused and such, as we heard, and it sounds like that's a lot where this amendment came from. So that is an assumption that is not always accurate. The amendment removes the exclusion and places the consequence over the life of the child, and that is something I cannot and will not support. We've said it before many times as we've been talking about this bill, but I personally want a live baby without prosecution, or prosecution with a dead baby. And that's exactly what you said, the death penalty. I mean, that That's something, and so if this amendment passes, I will not be voting for the bill as well, because it completely takes away from the heart and soul of the bill.
Thank you. Representative Kofalt and then Representative Shapiro.
Thank you, Mr. Chairman. So I guess I want to return to the logic that is sort of the basis for this amendment, because there is an assumption that a parent, well, let me see if I can figure out how to articulate this. If a parent drops off a child and there is evidence of abuse and there is no exclusionary rule, then there is an opportunity to prosecute that parent and use that evidence. If they don't drop off the child because it's clear that they could be subject to prosecution, it's highly likely that they are not going to drop off the child. There was a statement at one point, I believe, that or a concern that would people even be aware. And I'm going to say that I think word travels very fast on the street. All it will take is one prosecution, and I think that will put in a permanent end to the use of these baby boxes or safe havens. So, you know, on the flip side, to say that we are allowing that person to continue abusing, I would actually argue that if we are not accepting their decision to surrender their baby, we are allowing them to continue abusing, because they're not going to surrender their baby. They are most likely, if they're an abuser, they are going to abuse that baby. They're going to abuse that child for many years. This is the conundrum. This is not, I mean, just like the analogy that you presented, Representative, I think it is a moral dilemma. It's not an easy thing to answer. It is for me, however. I will take the uncomfortable choice over what I personally believe is the really, really bad choice. I would much rather have that baby in a safe place than allow that situation to continue and the abuse to continue.
Representative Shapiro.
Yes, thank you, Mr. Chairman. And thank you for Representative King for articulating in such an eloquent way the almost impossible dilemma that we have here. So my question is for someone who is smarter than me. Since Roman numeral 1 is already in statute, and what is added is Roman numeral 2 on line 29, can somebody articulate the difference between the two of those? I mean, my impression is that we're giving greater immunity, but I don't really, from just reading that, I don't really understand. There's already, in statute, there's already a certain immunity. So if someone could explain the difference between Roman numeral 1 and Roman numeral 2, I would appreciate it.
Representative Leon.
Thank you, Mr. Chairman, and thank you for that question. So this one does prohibit in any claim at law or in equity, but it doesn't have any claim that's for anything that's through rulemaking process. So if you look at it and you look at any of the rules that would happen through DCYF, where they might go for other children that are in somebody's care or go after them through something that's in rules. We have a lot of other areas that are addressed other than just in law and equity. We have a special committee on due process in DCYF, and there's a lot of stuff that happens outside of the laws that we set here in the legislature. There's a lot that we've just sort of set to let them do as part of their process. So this would allow for, you know, if you look at it too, we had people that were talking about the necessity because they seem to be more interested in prosecuting parents than they were in getting the children out of the situation. That was my read of the situation, and that may just be because I'm so concerned. We all look at the potential risk and the potential harm separately. I would rather have the child out of the dangerous situation over the prosecution, but some of the testimony was talking in a way that made me think that they had different priorities. So That's why I think that the section 1 that's already in law isn't enough, because they said that they said that they were looking to go for prosecutions.
Representative Shapiro?
So Roman numeral 1 does not include immunity from legal prosecution?
It was my understanding that they were looking to take action against parents with what would be an existing law. So the existing law was not going to preclude them from taking action against parents. I'm not a lawyer and I don't know the difference between all of these different aspects.
Yeah.
That's why we're trying to get into it
I don't
within
either.
DCYF. But it sounded like if we kept the language the same and removed section 4, if we kept those words in law, they would be able to take action against parents even after they had dropped off their child. I'm not sure exactly what action that would be, but they said that it would take away the ability that they had with the current law.
Representative Cofalt and then Representative Merchant.
Thank you. So the answer is that under current law, criminal prosecution is indeed possible, and that's what happened in the Dauphinot case, I believe is the last name. Dates back 2 or 3 years. Yeah, it actually was a murder case, not of the child who was being dropped off, but of a child that was previously in that person's custody. But information was collected during the drop-off process, and that sort of triggered a series of additional questions and leading to that. The defendant in that case said that she never would have dropped off her baby at the safe haven had she known that she would have been subject to prosecution.
Representative Merchant.
Thank you, Mr. Chair. I have before me something maybe the committee wants to discuss, or maybe I can work with Senator Representative King on it, Seth King. It basically says the parent acting pursuant to this chapter shall not be subject to the petition under RSA 169C, alleging neglect based solely on the actions described in this chapter. And that section, by the way, goes back to the Child Protection Act. So what I heard before with the attorneys is that if all of a sudden through the investigation they find the person has an issue with drug abuse or has been fraudulent about certain things, which has nothing to do with the child, that's the concern they had, because all of a sudden that evidence they find is no longer admissible. That's not, I think, the intent of what we're trying to do here. We're trying to protect the parent who decides to drop a child off, that we're protecting both the parent and the child, but not absolving them of all the other things that could come before, such as they were selling drugs illegally, doing things, if you will, that we need to protect, because if that's activity going on that's masquerading because of this dropping off the child, I don't want to prohibit that either. So maybe I can sit down with Seth King and we can work on maybe another amendment to deal with this.
Okay, our Representative Shapiro, and then before we go to you, Representative, we were just talking, and it's noon. We were thinking maybe continuing this discussion until after we reconvene at 1 o'clock and deal with 1585. But why don't you make your comment, and maybe during lunch we'll be able to come up with some ideas too.
Okay. So I'm not really sure I understood the distinction between Roman numeral 1 and Roman numeral 2, but however, I wonder if in crafting a different amendment that different kinds of law breaking could be separated, so that somebody could not be prosecuted for letting their, for dropping their child off for unrelated crimes, like, I don't know if they're unrelated, but crimes such as drug use or drug selling or dealing, but that they could be still, that there could be a narrow exception for if it was for assault or abuse of the child, and that would still not be excluded.
Representative Merchant.
And that's what basically, by exempting them from RSA 169C, which is Child Protection Act, that means anything in that act which deals with the abuse of a child and so forth is not admissible. Anything beyond that, such that they're dealing with drugs, other illegal activities, is not protected.
All right, last comment, Representative Kofalt, then we're gonna continue this till after lunch.
Thank you, Mr. Chairman. So I guess I would offer a scenario, because I want to return to the idea that this is excluding evidence that emerges as a direct result of them dropping off a baby at a safe haven. It does not prevent prosecution. It simply excludes certain evidence. So if you imagine, for example, that a mother is in an abusive relationship, the husband or boyfriend is abusive to the child has bruises, the mother has to ask the question, if I bring my child to the safe haven box covered with bruises, am I going to now be a suspect? I would expect so. Am I now going to be potentially subject to criminal prosecution? Imagine that, that same child was observed with bruises by a neighbor days before. Prosecution would still be possible, but they would have to exclude the evidence that the child had bruises when they were dropped in the safe haven box. So, I mean, it's again, we're sort of coming up with scenarios here, but I'm concerned about the idea of starting to parse different types of crimes. I think, bottom line is I'm pretty firmly of the belief that, it's more important to protect the life of a child than to have a 100% prosecution record. I think, we absolutely should hold people to bring people to justice. But if we have an opportunity to save a child, we should do that.
Okay, at this point, why don't we recess until 1, at which time we'll take up 1585, and then we will resume our discussion of 1607 subsequent to that. So we'll stand in recess until 1 p.m. Rhoda, you were here, I believe, to speak to an amendment.
Actually,
Actually,
I can move her amendment, actually.
okay.
So, I'll move that we adopt amendment 0908H. And hopefully there'll be a second so we can discuss this.
Representative Shapiro second, so please come forward and thank you, welcome and thank you for being here.
Could I also invite Ms. Nato, who was part of the team that put together the, okay.
Sure. And for the record, what's your name again, please?
My name is Sarah Nato.
Okay, thank you. And yeah, you with HHS or where are you from?
I am the owner and administrator of Carriage Hill Assisted Living in Madbury.
Okay, thank you.
So as a result of the request that the committee made regarding the First Amendment that was presented to the committee, a team was put together of the stakeholders for the amendment, and it consisted of the New Hampshire Association of Residential Care Communities, the Council on Aging, DHHS, OPLC, the Board of Nursing, and the Association of Nurses Association. Because all these individuals had concerns and really held a piece of the necessary changes that had to be made. And through significant hard work and a lot of discussion, the committee, this subcommittee, came together with an amendment that's being presented to you. And it's something that everyone agrees with. And I think that it's an example of good legislation because it does address a need that that New Hampshire has, and yet the bill, the amendment before you, is something that all the stakeholders are pleased with. And if you'd like to address any specific questions, or maybe Ms. Nato can go over the process that we used.
Thank you. Proceed, Ms. Nato.
So I'd be happy to give a quick summary of the amendment. So this bill is regarding medication administration in what are commonly referred to as assisted living, which are supported residential care homes or residential care homes. So currently in our facilities, only RNs, registered nurses, LPNs, licensed practical nurses, or medication nursing assistants, MNAs, are allowed to administer medication to residents. And that is one of the primary reasons why a lot of our residents are in assisted living, is because they either cognitively or physically need assistance with medication administration. There is, however, a significant workforce staffing issue. So it's a resident safety concern that we do not have enough staffing of RNs, LPNs, and MNAs to adequately staff our facilities, and therefore it puts residents at risk for safe medication administration. So currently the pathway for people to be able to administer medications is either to be, obviously an RN, LPN, or an MNA. MNAs are LNAs who have worked for at least roughly 2.5 years full time before they can qualify to take the MNA certification course. So we have a lot of staff who are nursing students going on to medical school. So for college students or even high school students who have their LNA. And because they're pursuing higher education goals, they don't meet the hours requirement, nor is it fiscally ideal for them to also spend the money and time to get those licenses. And yet they're a very qualified staff to be able to safely administer medication. So we're trying to create a different pathway. So we will still have the path of RN, LPN, or LNA to MNA to be able to administer, but we're also creating a pathway where PCAs, personal care assistants, who are unlicensed staff who do essentially the same role as LNAs in our facilities, to be able to take a course that will be 40 hours long, defined and approved by the Board of Nursing. It will be a certification so that we do have safeguards in place such that if they are not, if they have a high number of medication errors, or we are suspecting drug diversion or situations like that, there is a board and a license that would be able to be revoked if they are not meeting, satisfactory requirements. So we have sufficient safeguards in place, including continuing education, 8 hours every 2 years specific to medication administration, so that we feel that they are fully qualified to safely administer medication. So we have called this new position a CALMA. It's a Certified Assisted Living Medication Aid. These staff would only be able to work in the residential care or supported residential care facility, so assisted living only. They must be a direct employee of the organization, so they can't be a home health care aide that comes in to provide care to a resident. They cannot be an agency staff member. They must be directly employed by the residents. And so we feel that this is going to open opportunities, attract more people potentially to the healthcare field, but still be able to, safely administer medications to our residents. And that's a critical component of what we do for our residents on a daily basis.
Thank you. Any questions? Yes, Representative Nadarapam.
Thank you for taking my question. So, I've visited people in nursing homes, and
This is nursing home.
assisted living. So there would be like a medical room where all the drugs are kept, and would these people be, putting the pills into the little white cups that then they go? How does that work? Because I could. Yeah.
So in the current rules that are defined by the Board of Nursing, there are different levels of medication administration. So we do have some residents who are still capable of fully self-administering their own medication. So if they have an order by their provider that allows them to keep it at their bedside, they may keep it in their room. Most of the residents in our situation in my building, our policy is that we fully administer medication regardless of their cognitive or physical status. So it depends on each home. They can devise their own policies. So it can be completely self-administration. It can be medication with assistance. But once you get beyond fully self-administering on your own, you run into the complications of it needing to be an MNA, an LPN, or an RN to administer it, because even self-administration with assistance has some barriers. Like they may be able to rip the package, but they can't put it in their hand. So there's restrictions. So this would help make it such that it's either fully self-administration or the CALMAs would be allowed to assist with the administration or fully administer the medication.
A follow-up, Representative Nadarapam?
So of course they're not the prescriptions are already written out and filled, so they're not making decisions about whether they're just 40 milligram 2 tablets, so that's fairly simple to bottle away.
Correct. So we are their home, we're their residents. We are not a medical treatment facility in the sense that we are assessing, diagnosing, or prescribing. All of the medications that we're administering have to be prescribed by a provider, and our staff are simply following the instructions on the label. So we argue that if you are at home, you can take your own medication without a class. Your daughter can set up your pill box for the week. Your friend can do it without any training.
Exactly.
So this is their home. We are simply following the orders. Most facilities also have an EMR that helps with that. We also, not all of them, but many of us use pharmacy services that pre-pack them. So there are a lot of safeguards in place, but yes, we are simply administering per the instructions on the bottle. If there were a medical emergency, we're calling 911 or calling their physician. We do not have the ability to assess or prescribe.
Okay, thank you. You made that very clear.
Representative Nagel and then Representative Merchant.
Thank you, Mr. Chairman. Thanks for taking my question. I'm trying to understand, and I think I do, but help me out. What's the difference between a certified medication aid and a CALMA?
Okay, so in New Hampshire, it's licensed nursing assistants, and they can work in locations other than assisted living. So you can have LNAs in the hospital setting. So their scope of practice is defined by the Board of Nursing. The difference with a CALMA is that LNAs have broader scope of practice, some of which would not be applicable in our setting as opposed to a hospital. So the reason that's important to have a separate and clearly defined position in assisted living is that an LNA would need to, They don't use M&As in a hospital setting. LNAs cannot pass medication in a hospital setting. So it's two very different tracks, only because LNAs have a broader scope of practice and can work in settings other than assisted living. Does that answer your question?
Yes,
Okay.
yeah, it's kind of what I figured. Is there a licensure now for them? So this is creating the licensure.
It's creating the license.
Representative Merchant and then Representative Thomas.
Thank you, Mr. Chairman. And also thank you for spending a lot of time on this amendment. One of the things I don't see in here, and I apologize for not bringing it up to Representative Grody earlier. There's no limitation, if you will, on what drugs can be administered. It goes by the nursing board. My concern is that injectable products, because many times that's where a lot of errors can gravely be made. There's nothing in this statute that says that prohibits them from doing it. So should we be thinking about somehow inserting some sort of language to be sure that we're not talking about injectable products, talking about non-injectable products?
Yes. So in the current statute as it's written now, it says medications and it specifies certain medications defined by route and dosage. And that's where in the rules, we would be looking to define that further. And we did make sure that clause was in there because we did have multiple discussions about that when we get to defining it in the rules, there is concern. We all are in agreement that it would not be injectables other than potentially pens. So yes, we are all in agreement, those involved in the committee, that it would not include any medications that you would draw up by syringe. We would still have to define if everyone's comfortable with it being, for example, insulin in a dialed up pen.
Mm-hmm.
Yeah.
Follow up.
Thank you. So in saying that, if that's the agreement of the stakeholder community, is there any harm by putting that language into this amendment, into the bill? To be clear about that?
Sure. No, I think we would just have to have a little bit more discussion on that as the committee to be able to further amend that, but I don't think there'd be any opposition to having that defined further in the statute as opposed to rule.
Thank you.
Representative Thomas and then Representative Leon.
Thank you, Mr. Chair. Thank you for coming here. My question along the lines of injectable medication, is there any concern for Schedule I drugs with these people?
So we do hospice and end-of-life care, and we do have residents who are routinely prescribed narcotic medications, even if they're not on hospice. And there was not concern because it's a very controlled environment in our setting. And again, we are strictly following the prescription, the specific order by the provider. But the reason we wanted to make sure this was a licensed or certified position is that so there would be safeguards in place, that it is a license that can be revoked if we have concerns about issues such as drug diversion.
Representative Leon and then Representative Shapiro.
Thank you, Mr. Chairman, and thank you and everybody else behind you for your hard work on this. My mother-in-law went through an assisted living facility, and we're unsure if one of the chains of events was about medications that either did or didn't get to her, or didn't get there correctly. Who ultimately holds the responsibility if there's an error by the CALMA, and who would be responsible?
Yeah. So in the amendment, we have specified that they're reportable to the administrator. And we also have specified that there must be either a physician, MD, DO, APRN, PA, RN, LPN must be available for consultation 24 hours a day, whether in person, electronically, by phone. So that if there were any question about the specifics of the order, they would be required to have somebody on call available for that. But ultimately, it does fall under the administrator to be responsible for the medication errors and also responsible for reporting if there should be any consideration of revocation of the license or certification.
Follow up.
And then as a follow-up, so that means that if somebody is not giving them or giving them wrong or something, and if it rises to the level of a legal claim against them, it would be the administrator that somebody goes after because the administrator is the one supervising them?
Yes.
Okay, thank you. That makes a lot of sense. I just want to make sure that ultimately there's somebody who's responsible for those edge cases to hopefully prevent the edge cases.
Representative Shapiro and then Representative Merchant.
Thank you, Mr. Chairman, and thank you for taking this question. You partially answered this question, but I was wondering about the 24-hour-a-day consultation, and you you already went over who provides that consultation, but I don't know how big your facility is, but are the facilities able to have access to that kind of 24-hour day consultation? Is that like, is it difficult to get? Is it financially onerous? Is it available?
Sure. So my facility is 24 beds, and I have a director of nursing who's an RN, and I have a associate director of nursing who's an LPN full-time. In my building specifically, I employ 4 RNs and 3 LPNs. There are much larger facilities that may even be staffed 24 hours a day by an RN, but we also run the gamut, and there are some very small homes, like six licenses, 6 beds. So we put it as available by consultation so that if they are interested in having Calma's work for them, they could contract with a service that would provide that. So it specifically just states that they must have someone available 24 hours a day, but it gives them flexibility, whether that's their own staffing or somebody that they could contract with to provide that service.
Representative Merchant.
Thank you, Mr. Chairman. Answer one of the questions about Schedule 1 drugs. A pharmacy cannot dispense a Schedule 1. So if I understand it correctly, you're only dealing with prescriptions dispensed by a pharmacist.
Correct.
So therefore it would
Yep.
exclude Schedule 1. Okay.
Okay.
Number 2, the administrator for the facility, are they required to have a license? Because what I'm trying to get to is that if we're going to hold them accountable outside of a liability point of view, do they have a license that is at risk?
So I'm an administrator. We do not hold licenses, but we are named on our license with DHHS. So when we apply for our license with DHHS to operate our assisted living, we have to name an administrator who is liable and responsible for the facility. So I myself don't hold a license, but I am the administrator named on my facility's license.
Follow up.
So what I'm trying to get to is what's the risk factor for the administrator outside of liability? I mean, a lot of times when you have a license that's at risk, you may perceive things differently than if you don't have one.
Mhm.
So if there's no license for the administrator to lose, outside of a liability issue, that's my concern. So I'm not quite sure where to go with that.
Sure. So I'm not sure if it would be okay. I know licensing is here from DHHS. I don't know if Kelly Keith is able to better answer that question, if she might be allowed to answer that.
I think it would be helpful, if I may, Mr. Chairman,
Sure.
is that if there's a way to say if something happens that you cannot hold another license, or you can't be an administrator at that facility or any other facility, that way there'd be some way to be sure you have sort of what I call skin in the game.
Good afternoon. For the record, my name is Doreen Shockley. I'm the manager of the Bureau of Licensing and Certification at DHHS. To answer your question, Representative Merchant, unfortunately, that's not a question that I could answer. It sounds more of a legal question in terms of liability. I can say that from the facilities lens, we license health facilities. We don't license individuals. So the administrator on record for all licensed facilities is the person responsible for all operations and activities that occur. But in terms of what Representative Leanna and you are asking, that sounds more like a legal question from a liability for the individual. So I'm not able to answer that question, but it's a very good question.
Representative Seth King.
Thank you, Mr. Chair. To piggyback on what the last 2 representatives were talking about, my understanding is that nurses at these assisted living facilities, they spend really the majority of their time handing out medication and dealing with medication. And they're constantly at fear of losing their license. Even if one little thing goes wrong, even if a pill goes missing, they're afraid that that could cost them their license. And that, you know, if these new Calmas don't have that sort of Damocles hanging over their head all the time, then it's just an interesting something to think about. I'm not taking a position on it one way or the other. And my question, though, for you is that I just imagine that if this new Calma position were created, that you could reduce, you said you had 4 nurses, you could potentially reduce 3 of those nurses' positions and replace them with CALMA, because they're like I said, so much of their time is spent doling out medication that if you use these, you wouldn't need so much nursing man hours. So could you address that a little bit, and as well as the licensing issue that the nurses fear of losing? Thank you.
So my RNs are not full-time, just to cover that, not full-time FTEs. But that is really the heart of this issue, is that there is a major shortage of nurses, LPNs, and MNAs, such that we are struggling to staff our facilities. So it's a resident safety issue caused by the lack of staffing. So we compete with hospitals and nursing homes for nursing staff. And for myself, my facility went 4 years, almost 4.5 years through COVID, where I constantly had open positions that I could not fill for what we generally classify as med givers. So that is really the concern and the impetus of this bill. The whole goal here is to create a safe pathway and a course where they are going to get 40 hours of training to be able to safely and effectively pass those medications, because we are not able to successfully staff and fully staff our facilities, and therefore putting residents at risk. So yes, it would allow me to use the staff, that is the goal, instead of nurses and so forth. And I think, as you all are aware, we have a major healthcare staffing crisis in this US. We have one of the oldest populations here in New Hampshire. We're at the beginning of the baby boomers. So we're trying to get ahead of this by creating this position so that we do have the available staffing to safely administer medications to our residents. And as I mentioned before, this is their home. At home, they're allowed to take it. We feel that a 40-hour class for our staff who are doing this as their full-time job are going to be safely qualified to do this, and that it's not necessarily the best use of a nurse in our building, just to be used to pass out medication. As far as the license, I can say that,
Elizabeth from OPLC would be able to answer more specifically the questions that you have related to the license and the CALMA and the responsibilities and liability.
Elizabeth Eaton, counsel to the Board of Nursing. And the Board of Nursing was pulled in as a stakeholder because due to the concerns about accountability for this new position. And so the Board of Nursing not only elected to be the jurisdiction over this position, but is eager to. They understand the shortage. And so I want to make it clear that this is in the Nurse Practice Act. They would have jurisdiction. And so a complaint could come in about a CALMA who is not passing out pills or is somehow messing up, and it would come to the Board of Nursing, and they would potentially issue sanctions.
Okay. Well, Representative Bohm, did you have your hand up earlier? Or?
No.
Oh, okay. Representative Merchant.
Thank you, Mr. Chair. So under line 14 on page 1, instead of saying certified by the office, licensed by the office, that way there they have a license, and therefore that could be pulled by the Board of Nursing.
So in 541A, the definition of license includes the word certification. And so a certification, even though it sounds different from a license, it is considered in New Hampshire a license. And so it's no different from a licensed nursing assistant or a certified assisted living medication assistant. They hold the same kind of license.
So if we're, thank you. So if they're synonymous, is there any reason we could not change certified to licensed?
That's something for the group to discuss. I think WALMA sounds a little bit more difficult than CALMA, so.
It's the only one. Come on.
I'm destroying it.
Other discussion? I'm seeing no other discussion. All right, thank you. Any other discussion on this amendment? Seeing none. Representative Seth King.
Yeah, I don't know how I'm going to vote on this amendment. It's sort of last minute, and I was originally OTP on the main bill because it was so clean and simple. And there's, at least it seemed like it, there was, and there's a lot here, and I kind of have mixed feelings about it. I mean, on the one hand, I like the idea because I do recognize that the nurses, they're totally understaffed, and they're maybe even more prone to making mistakes because they're so understaffed, and this could help free up some of the problems we see in assisted living facilities. I don't know. I have mixed feelings. I'll probably go along with it though.
Okay. Other discussion, Representative Nagel.
Thank you, Mr. Chairman. Thanks for taking my question. Are we inventing something or does this exist elsewhere?
So we are inventing something. Well, we're taking something, copying something that already exists in Maine, and I believe just Maine right now. Maine and Massachusetts. But I also kind of wanted, there's a lot more people here than at the session that we were at the end of January, I believe it was, or we're just in a much smaller room. So I wanted to give a little, okay, very good then, because I just wanted to give a little history, actually, to Representative King, to your point. We had come in front of the committee with a First Amendment. I think it was the end of January, because we were asked at that point, we actually did suggest or recommend that it go to study committee, and that the group behind me and others that aren't here get together and kind of explore this, because it's very large and it's very important. We were advised at that meeting to come up with a report to present to you today. Representative Shapiro asked if we could do that soon. We said, sure. And so through that process, we ended up surprisingly with an agreed upon amendment to create an entirely new position in the state of New Hampshire that replicates what's in Maine and Massachusetts that's working well for them. So I just want to give a little bit of context. We're certainly open to studying this more, but really believe if something's working in our sister states, that it would be something that we would want to consider doing here as well, if that's helpful.
They're not listening, so I can ask it. Does the
Representative
let's try to sneak her in there. So the 40-hour course, does that exist already, or will that have to be created?
It will be created.
And do you know what a time frame for that would be?
Well, I think the amendment says this act takes effect 60 days after its passage. So I think we have a lot of that done. I don't know. It's a lot of, yes, as quickly as we did a lot of work really fast. So I'm hoping that we would do the same going forward. And it's a very, it's a collaborative group across all agencies that have worked really well together.
Representative Merchant.
Thank you, Mr. Chair. I noticed in the original bill, there was rulemaking authority given to the Board of Nursing. But in the amendment, that goes away. So I want to be clear, we don't lose that rulemaking authority by inserting the amendment, because it's basically replace all. So I want to be sure that we don't somehow inadvertently not give the Board of Nursing rulemaking authority to create the exam and so forth, et cetera.
Give me a moment to find where it is in the amendment, but the rulemaking authority is still there.
We'll find out if it's even necessary.
Wouldn't? Yeah. I mean, if you're inserting this into the nursing practice act, wouldn't it?
And if it isn't, well, so here's what it is. Here's where it is. They already have rulemaking authority for all licenses, for all persons licensed under this chapter. And so under 326B, any license type, they have rulemaking authority over. And so they didn't feel the need to specify.
I would I would caution against that. I think if you're not opposed to it, to insert language in there that's very clear you have rulemaking authority, because I know sometimes the legislative body has a tendency to not look at when it gets to GELCAR and want to be clear that you have rulemaking authority in the act itself and not something referring back to a broad rulemaking authority, just to be on the safe side.
Thank you.
Other questions?
Apparently I do.
Representative Naylor, your microphone is on and your hand is
Sorry.
raised.
I've been urged by one of my colleagues to ask you what they call this in other states and what the acronym is.
So Maine used certified medication aid, and we were advised to not use that because it's too close to CRNA, a certified nurse anesthetist, CNA. So that's why we deviated from that. We also wanted to be very clear that this role can only work in HEP 804 and 805, the supported residential care homes. So we made sure we put assisted living in the title so that it was very clear that that is the only place this license would be in effect.
Other questions? Seeing none, okay. Thank you. Any other discussion on this amendment? One question that has been raised, and is Christina back there? Well, and you probably can't answer this. There's a question as to whether this amendment would be considered a germane amendment or not, where it creates a new position. Yeah, well, we're doing that right now, but I didn't know if you might have any insight into that. Okay, yeah, we're doing that right now, but I didn't know if you had any thoughts or any insights on it. Yeah, I would think that, you know, and Representative Weber is a co-sponsor, and she usually has a pretty good sense of these things also.
Mr. Chairman?
Yes.
When I look at the original bill, it's referencing a different RSA, which is facilities. This is referencing something more towards the Board of Nursing. So I think having the clerk weigh in on this would probably be helpful and wise.
Okay. All right. Again, we're emailing him right now, so hopefully we'll have an answer. Okay. All right. So obviously we can't really vote on this at the moment. I guess what we could do is revisit 1607 in the interim, and then come back to this. Representative Shapiro.
Thank you, Mr. Chairman. I just have a question about procedure. If it is a germane amendment, there were two smallish changes that were brought up, one about injectable medications and one about rulemaking authority. Is there any way to vote on this amendment and have those put in later, or would we have to have the amendment rewritten to include those?
Well, once we vote on this bill, we're done with it in terms, Representative Leon.
I think we need to have that drafted, and I know that OLS is, they're working to get everything to everybody who needs last minute things right now. So I think we'll find out if this is germane or not, and if it does need to have a separate hearing. And regardless, we'll probably want to end up execing this one on the 20th, most likely, just so that we have a chance to digest it, even if it is germane. I like it a lot. But I just want to make sure we're doing everything in the right process and we don't end up having a wrench thrown into the works at the last minute and lose all of this really important, valuable work.
I just hope that we can ascertain that we're all in agreement today with the rewriting so that we don't have to relitigate the whole thing on the 20th.
I know that I personally am. I guess if anybody has any questions, I'm not trying to jump in on this. We probably would be able to hit a calendar deadline if we do this quickly to have a non-germane hearing. We'd be able to have those of us who need to be here for it, and then have an exec on the 20th would be my thought, just to make sure we're doing everything on the up and up. But if anybody wants to speak up, especially if they have problems with it.
Representative Palazzo.
I support moving it to 20th, but I don't see the need to further amend like was said, because it's already in this chapter. It's already under this board, so I don't think we need those two amendments to this amendment. But it's just my opinion.
Okay. Any other thoughts, any other discussion? Okay, well, I sense that we want to move this to the, there's enough concern to move this and continue it to the 20th, where we have several other bills already. Certainly not a whole day's worth, but we will be meeting on the 20th, so. But I would need a motion. I would need to have you withdraw your motion.
I'll withdraw my motion.
And who seconded that? Representative Shapiro, you withdraw your second? All right, so we'll continue HB 1585 to, we'll continue that to the 20th. Thank you, everyone who testified and offered information today. Okay, moving on, we'll find out about, again, about the, whether or not that amendment is germane. All right, let's get back to 1607 then. Representative Seth King.
Thank you, Mr. Chair. After having done some discussion with Representative Merchant, I've decided to withdraw my motion of the amendment so that hopefully we can get some time in discussing this in a little bit further detail. Maybe we come up with a different amendment to that. So for now, I'd like to just withdraw my motion.
Okay, who made that second?
I did.
Okay,
I will
Representative
also
Merchant
withdraw.
withdraws, okay. So that amendment is no longer before us. So what is the thought? Is that this also something we're going to continue, or we want to continue, or?
Yeah, that would be so that we can continue this on the March 20th. Yeah.
Okay. Okay, well, March 20th is getting to be a busier and busier day.
Long day. It's okay.
Okay, moving on then. The next bill up is 1615. Representative Kofalt, I believe you had a motion?
I do. I have an amendment which I will pass around. Pass those on. So I move ought to pass with amendment 2024-0881H.
Is there a second?
Second.
Representative Merchant seconds. Representative Kofalt, do you want to speak to your motion?
Sure. So you may recall that during the hearing, the bill's original sponsor indicated that his preference actually would have been to repeal the autism registry outright. The department weighed in and said that they were unaware of anyone using the registry for data analysis. They don't have any objection to repealing it. And I also spoke with two co-sponsors of the bill who also believe that an outright repeal would actually be preferable to the bill that was presented. I think they didn't go that far with the original bill simply because the prime sponsor didn't think that was necessarily achievable. But having spoken to a number of people, it seems like this is the preferred option. So briefly stated, what this bill does is it repeals the autism registry, it repeals rulemaking relative to the autism registry, and it directs the Department of Health and Human Services to make all reasonable efforts to destroy the individual data records. That means that they could retain aggregate information, total number of people diagnosed with autism in any given year, but they would be destroying the records that pertain to individuals. One of the key concerns here, of course, is that it came to light in the hearing that there's a great deal of personally identifiable information in that registry, and that nobody is giving consent to be added to the registry. In fact, many of them are not aware that they or their family members are in the registry. So for that reason, I bring this amendment which modifies the bill to simply repeal the registry altogether.
Okay, any other discussion? Representative Palazzo.
I like the intention, but I probably will vote against it because I'm concerned about unintended consequences to taxpayers, and it could be twofold. First of all, there's a interest, if there's a growing problem, for example, of occurrence of autism, there's an interest in to figure it out. Like some would say it's completely not connected, for example, to vaccination, but let's prove it. Yes, the HHS maybe not using that registry for these purposes. Maybe it should. So that's concerned that instead of trying to figure out the problem, we are destroying data that potentially bring awareness of what's going on and why it's going on. And second concern is like receiving services, so potential abuse when person or family want to receive services for certain medical condition, but then they also want to receive other services saying that they don't have this condition. So having it both ways, it's a second potential unintended. So I'm thanking for your effort in supporting autism community, but for me it's not clear how it will be with unintended consequences. Thank you.
Representative Thomas.
Thank you, Mr. Chair. This is a question for you. So in my town, we have PFAS contamination, and chronic PFAS exposure is associated with autistic tendencies. So I understand getting rid of this list. I agree with it. However, is there a vehicle that remains in New Hampshire to gather information, including personal information on autism, so that we can correlate it to exposure?
Thank you for the question. So I'm not aware of what the Department of Education has in terms of the comprehensive nature of their data, and I'm not sure to what extent they're barred from sharing that data. So because the Autism Registry tracks diagnoses, it tracks diagnoses. So there are potentially people who lived in a certain town, were exposed to something and moved, or got vaccinated or not and moved. It doesn't, I guess, is not relevant in that case. But there may or may not be records in New Hampshire of an event that could be correlated. So I guess the short answer is no, but I also don't think that the current data necessarily sheds much light on some of this. I think it certainly doesn't shed any light on vaccination correlating because there's no flag in there currently for what vaccines a child has received. So I guess the biggest concern is that, you know, the registry currently includes the last four of people's social security number. It includes the town, the age, there's so many variables that it includes that a reasonably determined person could back into, personally identifying the people on the list. So although I certainly appreciate the intent behind the question, I think the answer is no, and I'm not sure that this data would necessarily help.
I wondered if there was another vehicle.
I see another hand up over here. Representative Shapiro.
I think maybe Representative Kofold covered it, but when DHHS testified about this original bill, they said that there were other more accurate, up-to-date efforts to keep track of autism, I think mostly through special education.
From what I understand from our researcher, that was not the case.
Oh, really?
Okay.
Okay. I missed that in the memo.
Okay. Any other, Representative Nattarappen?
Thank you. In this committee, we've tried to start registries for several other conditions, ALS, whatever. So I was touched or something by the parents that came to testify to say they didn't want this registry. So I'm going to go with the parents that, you know, they have the lived experience of their child with autism, and they didn't want this registry. So I'm going to vote accordingly.
Okay, thank you. Other discussion? Seeing none. Okay, the motion is ought to pass on HB 1650 -FN, the amendment 0881H. Again, this is on the amendment. Last clerk to call the roll.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yes. Representative Polozov,
No.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-1.
Okay. Do I have another motion, Representative Kofal?
I move ought to pass with amendment.
Second.
Okay, motion's been made and seconded. Any other discussion? Motion is ought to pass as amended on HB 1615 FN. If there's no discussion, I'll ask the clerk to call the roll when he's ready.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Polozov,
No.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
19-1.
Okay, is there any objection if that goes on consent? Actually, is that an appropriation on that?
No.
No, okay.
We can always try, and they can pull it off consent if we
All
break
right.
the rules.
Okay, we'll put it on consent and see what happens. There you go, there you go. Well, every time you see an FN, you know, you have to get a little nervous. All right. Oh, well, we don't get nervous around you, though. So the final bill of the day to be considered is HB 1683 FN. Representative Leon?
Yes, I have it in my paper. I'd like to move amendment 0573H and, sorry, thank you. This should be coffee, not water. I would like to move amendment 0573H, and I'll pull that out of my notebook and share it. Like I said, it should be coffee, not water.
Okay, I'll second that amendment. We did. We
Wait,
did.
what did we do? We continued it? We didn't,
Which one?
the safe haven?
We continued it.
Oh, okay, we didn't, I thought we were going to discuss another potential amendment.
Well, we did, but they're not ready for it yet.
Another one that we add though, but, we can.
So it's gonna be, about 6 bills on that day, which is certainly doable. But that means 6 reports that have to be written right away that day. Yes. That was consent. That was an easy one.
1712, the amendment, we couldn't do because it was chapter law, not statutory, so we passed it out to pass on consent.
Well, Christina, you'd like them today, right? So you can get them in the calendar for next week? What's that? They probably won't make it then? Because they've got to go from you to Paul to the speaker. So, all right. But, yeah, I mean, I don't know, today, tomorrow?
I would guess ASAP.
I know we have session, but what are you doing tonight, Joe? Yeah, we'll go over that. As soon as we get this last bill done, I'll go over what I have.
And I guess if I can get sort of nods or any of that once people have read through this so that I can then talk through it. I know I just didn't want to talk while everybody was reading, but I guess we have it in front of us now. One of the concerns had been other medically necessary conditions. So on lines 4 and 5, it adds or any diagnosed condition for which a circumcision is deemed medically necessary by a physician or other healthcare provider licensed in New Hampshire. The other concern was regarding the fact that there was prior authorization. And line 7 amends the bill to remove the prior authorization requirement. So those were the two main issues that were raised on the substance in those areas, which would be more technical issues as opposed to any potential philosophic differences.
Representative Merchant.
I want to say thank you to Representative Leon for the amendment. One of the things I have in my notes, and maybe it's something that is not germane here, it's also for religious reasons. So this is medical, which I understand, but there could be certain religions that may either require it or want it and so forth. Is that going to be covered?
If I can answer that.
Sure, go ahead.
In my understanding, the religious circumcisions don't happen in the hospital. The religious circumcisions happen outside of the hospital with a non-medical provider. Okay. Well, okay, so then we need to get into the other philosophic question. Philosophically, we have problems with money, say education money, going to religious institutions. When you're looking at this religious thing, the question is, you're looking at Medicaid going for something that's purely religious as opposed to something that has some sort of medical requirement. So when you get to a purely religious ritual type circumcision, those ones are absolutely happening outside of the hospital. When there's the general leaning, just like the times when I filled out on the religious form, generic Christian, that's what I had filled out. You know, there's the question of how closely tied it is. So I don't know if there's still more concern, but we're trying to get as much as we can.
I would say, based upon this, if I may.
Sure, go ahead.
Thank you. That you raised a good point, and one I lost sight of. Medicaid is medical insurance and only can be used for medical reasons. So, given that statement and what you just said, I could support the amendment.
Representative Shapiro.
I was just gonna, as the committee Jew, I was just gonna clarify that, in the Jewish religion is one of the religions, along with Islam, where people are frequently circumcised. And I think there's a great variation. Frequently, circumcisions happen in a ritual manner outside the hospital, but I think there are a lot of Jews who believe that their children should be certified, who may be more secular or might not be having that kind of ritual tradition and might have their child circumcised in a doctor's office or in a hospital. To me, it's not really the relevant point in terms of my feelings about the bill in general. So I don't really think that that's an issue we should vote on.
Representative Seth King.
Thank you, Mr. Chair. Thank you for bringing forth this amendment. I definitely like the part, line 7, by getting rid of that one part that it does, Roman 5. I'm just curious, K says, or any diagnosed condition, and I'm just wondering why we leave in all of these other specified conditions if we're going to have like a catch-all phrase anyways. Why not just get rid of A through J and then just make K it's got to be medically necessary? Why do we have to specify all the other ones?
Well, thank you. That is definitely one point of being able to just wipe all of those out and say just medically necessary. But we also look at the fact that we had another bill on informed consent and recognizing that there are medically necessary reasons for circumcision. I think just into that whole dialogue that hopefully we don't keep rehashing, but into that whole dialogue, it does put in statute that there are those there are those medical reasons for it as well. And I think that just sort of helps in the conversation. Nobody really prints out. Very rarely are the statutes printed out, so I'm not going to worry too much about the amount of ink by having those additional lines. And this was one that was proposed by the prime sponsor of a way to address the concerns.
Representative Nagel, and then Shapiro.
Thank you, Mr. Chairman. I had a question about what you're replacing on section 5 from the original bill, or getting rid of. What actually is a pre-authorization?
So a pre-authorization is when you need to make sure you get approval before you do something if you're going to get paid for it. At least that's my understanding.
Because we use the term prior. I've never used the term pre, and that's why I was confused by that, whether it's a pre-authorization from the patient or a pre-authorization from the insurer.
I'm not sure if the language in the bill is the correct language, but either way, it's gone.
Okay, perfect. You answered my question and solved my problem. Thank you.
Representative Shapiro.
Yes, so I'm going to vote against this amendment, and it has nothing to do with religion or religious exception not being included. You know, when one is looking for information outside their area of expertise, I don't know about you, but I tend to go on the internet, and one looks, and clearly you can find information on the internet that says circumcision is not only unnecessary, but is damaging, is mutilating the body, et cetera, that there are no health benefits. But I think most of us would acknowledge that you can also find information that says that there are medical benefits. And so, I mean, we could argue, I don't think we're equipped to argue which is true or more accurate, and I'm not really interested in that. But I would say that in my mind, circumcision is not a cosmetic procedure, but it is an elective procedure. And I do not think that that boys should get circumcised. I do not think that they shouldn't be circumcised. I think it's parent choice. I think a reasonable parent could feel that there is some medical benefit, and a reasonable parent could feel that it could be potentially very damaging. Although in my mind, some of the stories that we heard were full of hyperbole. But so I think it is an elective procedure. I think people are doing a good job about educating people, and maybe there's more that could be done about in terms of education. You know, once again, you can read all kinds of rates, but I think the rates have come down from like my generation, where 85% of boys were getting circumcised, to now it's more like 50%. So things are changing, the norms are changing, and I think it's probably a good thing. And I think it's probably because people take bodily autonomy more seriously, and people do a lot more research into their own medical care. And so I think that that's probably a good thing, and I think education is a good thing. However, I think that this has been a culturally acceptable procedure. I think it's been, one can make the argument that it has medical benefit. And I am against, from an equity point of view, taking that reimbursement away from low-income people. So I would vote no on ending the Medicaid coverage for circumcision.
Other discussion? Representative Bohm.
Thank you. And you mentioned, Representative mentioned Islam, for example, but nothing in this bill that I read says male. There are female circumcisions. So, I mean, so what are we covering here? Males and females or both? And I know Islam had the thing in some countries of female circumcision. So we have a problem here, I think.
Representative Shapiro.
I believe that we have a New Hampshire statute outlawing female circumcision.
Yeah, I don't know. Any other discussion? Representative Merchant.
Thank you, Mr. Chair. Like my colleague from Keene, initially was opposed to this bill because concerned about creating two classes of medical care, those for the wealthy and those who aren't. But given the fact that we changed this to any diagnostic condition, and based upon the fact that Medicaid, the way it's written, is only for medical procedures, I could therefore support the bill, particularly with line 7, deleting the reference to a prior authorization. So I will be in support of the amendment and probably for the bill.
Thank you. Representative Nagel.
About the amendment now, correct?
Yes.
Not the actual bill, because
Right.
I have issues about the bill itself, but.
Any other discussion on the amendment? Seeing none, I'll ask the clerk to call the roll. The motion is ought to pass on amendment 0573H.
Representative Leon,
Yes.
Representative Bohm,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yes. Representative Polozov,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
Yes.
Representative Harriet Gathright,
Yes.
Representative Palmer,
Yes.
Representative Tejas,
Yes.
and Representative McDonald,
Yes.
18-2.
Do I have another motion? Representative Leon.
Thank you, Mr. Chairman. I move ought to pass as amended by amendment 0573H on House Bill 1683.
And I will also second that as I did the amendment. Any discussion, or would you like to speak to your motion?
Thank you. Yes, I would like to speak very briefly to this motion. I'm sure none of you, after getting to know me, would be surprised to know that I came with a binder like this with clinical data when I went to the hospital with my kids. So I recognize the idea, and there was clinical equivalence, and that was actually something that I supported, and I even had to get some exceptions to other things in order to do that. As for the idea about the potential of this being discriminatory, I think that everybody is coming to more awareness of this. And I think that this remains a personal choice. And I think that it's one that, because Medicaid is for medical reasons, any parent who's seeking it for a medical reason, which you can find in the literature and you can support. And if there's a parent who is really saying, this is really important to me, as they're being informed about the risks and the benefit of the procedure, the doctor will tell them about the potential data where there could be fewer UTIs if they were to get a circumcision. So I feel that any parent who feels very strongly would be able to have a medical indication that they could express to the parent, yes, that the doctor, that yes, that is important to me. So I feel for those parents who really feel strongly, they will have, there is clinical equivalence at least about it, that they'll be able to point to something. My other concern too is that if it's just sort of a one-way conveyor belt where you're finding people who are on private insurance making more, stopping and thinking about the decision more than people who are on Medicaid, if it's just basically part of an established pathway, that you may see some difference in equity around what the rates look like in the Medicaid population versus the non-Medicaid population. I don't want to do that study. I don't want to look at that study. But since Medicaid is for medical reasons and everybody's evolving in their viewpoint, I don't think that it's a discriminatory bill.
Representative Nagel and then Representative Merchant.
Thanks, Mr. Chairman. Since I lost so much sleep over this bill, I just wanted to point out a couple things that I think are somewhat less relevant now with the amendment, which I actually do like. But this bill only applies to Medicaid. So what I tried to do is figure out, well, how much does it actually cost to get a Medicaid circumcision? And it's actually, it's a money loser. The doctors don't make any money doing this. The states that have actually done this have seen the rate of Medicaid circumcisions drop by about 50%. And what was really interesting is when they looked at two of those states, the Medicaid reimbursement for circumcision actually increased. And the reason why was because they weren't doing it in newborns. Now they were doing it in 3 or 4 year olds when the risk benefit ratios and the cost benefit ratios are a lot less favorable. And so they were dealing with a much more expensive, much more risky procedure. So if this is supposed to be a money-saving bill, I'm not sure anybody's going to be really saving any money by doing it, by passing this bill. And I kind of get the impression that was the reason for the bill in the first place. The last thing I did want to point out that I thought was also important, that I thought the testimony that we heard for several hours was a little bit misleading in them claiming that this is a cosmetic procedure without any medical benefit. And then they cited all the major medical organizations. That's not what the medical organizations said. The American Academy of Pediatrics said that the risk-benefit ratio actually favors doing this in the newborn, but the benefit is not sufficient to justify universal recommendation except in a couple circumstances, which the World Health Organization, the CDC both said. Followed up on is that if you live in an AIDS endemic area, you should do this in a newborn because your risk is unfavorable. If you live in an STD unfavorable environment, that you probably should do it because the risk benefit ratio is more favorable in those regards. After that, I agree it's a personal choice, but to just diminish this as genital mutilation and cosmetic is really inaccurate.
Representative Merchant and then Representative Shapiro.
Thank you, Mr. Chair. My understanding of Medicaid, I don't have the depth of knowledge maybe I should have to make the comment. But everything I've learned about Medicaid is it's medical insurance. And the only time medical insurance will pay for something, whether it's private or public, is when it's medically necessary. If it's something that's elective and not medically necessary, cosmetic and so forth, most private insurance companies, along with Medicaid, will not pay for it. So my concern of having two levels of care based upon that comment basically goes away. Given the fact we don't have prior approval or prior authorization required anymore, I feel comfortable that we're not creating two classes of care. If the medical provider deems it to be medically necessary, Medicaid will pay for it. If they deem it not to be medically necessary and it's something selective based upon either religious reasons or other reasons whatsoever, that's really up to the parent to make that choice, just like they would with private insurance. So I don't think this is going to be a two-tier system of care.
Representative Shapiro.
Yes, I would like to address the equity issue, or as Representative Leon said, the issue of whether it's discriminatory or not. And I would say that if we pass this bill, we're essentially saying that it's not medically necessary. And we're passing a bill to say Medicaid no longer will cover circumcisions. And now you can read the fine print, but I think what we're basically saying to the state of New Hampshire is that this is a procedure that Medicaid will not cover anymore. And that's the message that we're giving. And that it will be left to anybody who is, I mean, we don't want it to be that the default is to kids just get circumcised. But we don't want it to be the default that kids don't get circumcised and that a parent has to bring their case to a physician and saying, well, here's the research, here's what I think is the medical benefit. So I think that it is an equity issue and that we are taking away a coverage from low-income people. And so, I mean, I know this, I disagree, and I think that I will definitely vote against this.
Other discussion? Oh, Representative Leon.
Thank you, Mr. Chairman, and thank you for that. I think that this isn't something that's about the funding and trying to save money from Medicaid as much as it is to have a discussion that it's not a default one way or the other, but it's a discussion. So I think that I believe that all families of all income levels are capable of having these discussions and talking with their healthcare provider, and that through the whole process, especially when you do have a multi-day stay with a birth, that you have this opportunity to talk with your healthcare team and have a discussion about the need for about the medical reasons behind circumcision. I don't think it's discriminatory to say that families, regardless of their income level, are able to make decisions about their child's care. And I know this is just one of those areas where we just have different approaches to trying to respect people and to respect where they're coming from. And I don't think that we'll ever come to an agreement on this, but I know that we're both coming from this from good points of view, where we're both trying to honor those families and make sure that they're protected. We just disagree on how to do that.
Representative Palmer.
So I do think the amendment helps the bill, but I'm opposed to the idea. Most of the decisions about what's covered are not legislated. They're made by groups of people who get together with all the evidence and decide whether or not a procedure is what coverage, insurance coverage for the procedure, whether it's Medicare, private insurance, or Medicaid. And I think the two things that go here is, one is that with more information, the trend is going away from doing circumcision, but I don't think we should legislate coverage. I think that the coverage decision should be made at a, not by legislators, most of whom, like even I don't, this is not something I do, so I really don't know about it, so I don't think I should be deciding it. That's.
Thank you. Representative Shapiro.
I would just say that in terms of the message to the public, we would be passing a bill that says this bill provides that the state Medicaid plan shall not include circumcision, and then it goes on to unless there are exceptions. And so I think that I think this is a bill that will make it very hard for someone to be reimbursed for this procedure, and I don't understand why we're doing that.
Representative Merchant.
And thank you, Mr. Chairman. Thank you, Representative Shapiro. I went online just out of curiosity. Anthem will only pay for circumcision if it's medically necessary. So back to the issue I think we're faced with here, Representative Palmer. We don't have an insurance company. If this was an insurance company, we'd be sitting around the table deciding upon what we want to cover through the policy. And that's how insurance basically works. However, because we don't have a corporation per se, we are, in a sense, the corporation legislatively. So we have to decide legislatively what we want to put into the policy that we cover for Medicaid patients. So that's where I'm coming from. And I looked at Anthem. A lot of the other ones, they don't pay for it unless it's medically necessary. So what I'm trying to make an argument for is that we're following the free market as well. So if somebody, unfortunately, was going to be an Anthem because they made too much money in Medicaid, they couldn't have the procedure done, at least be paid for by somebody else.
Representative Palmer and then Representative Shapiro.
But I wonder how Anthem would respond if we started legislating what they pay for or not.
Response, Representative.
It's a good point. I hear you, but we're not legislating as who should we turn it over to the Department of Health and Human Services, an agency, let them decide what the policy should be? Someone's going to make a choice about the policy. And we don't have a corporation to make that decision. So how do we do it otherwise? How would you do it?
Representative Palmer.
Well, so Medicare makes its own decisions. I mean, why don't we keep, I'm just saying, we can't, as a legislative body, sit down and take all of the medical diagnoses and decide which ones we're going to pay for. We're not qualified to do that. Maybe there needs to be, a commission or something, a group that does that for Medicaid. I don't know. To be honest, I don't know how it works now, but I just don't like the idea of starting to take pieces of it. And who knows what the next one will be where Medicaid's not going to pay for bypass surgery now. I don't know.
Representative Leon.
Thank you. I'm just trying to find the, let's see where it is. So we were discussing something similar to this earlier today on House Bill 1568, where we were talking about adding more coverage to Medicaid. And I was corrected that it's not Commerce, it is Health and Human Services. So we are the body. We are the ones who decide how state revenues are used in the Medicaid program and which services to provide. So, honestly, maybe at some point the Health and Human Services Committee, if that becomes a bigger thing, can act like Commerce and have subcommittees that are dedicated to Medicaid coverage, and then we can get that expertise. But this seems to be consistent with what's happening in the market, and perhaps having that consistency is the least discriminatory of all.
Representative Shapiro.
Several weeks ago, regarding a different bill, I had the opportunity to speak to Rob Berry, who is the attorney for Medicaid for Department of Health and Human Services. I was actually asking about coverage for other things like cosmetic, breast reductions, and breast augmentation. And he made it clear that those things weren't covered. And what he said to me is Medicaid only covers medically necessary procedures. That is already the case. And the fact is that they consider this a medically necessary procedure. So I don't know why we're taking this one issue and interceding on behalf of this one particular issue and one particular advocacy group that has strong feelings about this one particular issue. I think the policy of Medicaid, New Hampshire Medicaid, is already that it only covers medically necessary procedures.
I think we're starting to go around in circles a little bit here and repeat ourselves. Unless somebody has something new, why don't we go to the vote? Anything new? I'm not saying it. All right, so the motion is ought to pass as amended on House Bill 1683 FN. I'll ask the clerk to call the roll.
Representative Leon,
Yes.
Representative Bone,
Yeah.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Lewicki,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel,
Yes.
Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Thomas,
Yes.
Representative McKay,
No.
Representative Freitas,
Yes.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
Yes.
Representative Harriet Gathright,
No.
Representative Palmer,
No.
Representative Tejas,
No.
Representative McDonald,
Yes.
14-6.
I assume there'll be a minority report? Who's writing the minority report on that? Representative Shapiro? Okay, that is the last bill for today. Let me just go down through the list so everybody knows what they're doing. And is Christina Dyer still over there, or she's not? So anyway, yeah, we're gonna miss the calendar for this, the deadline for today. So if you can get it to me by the end of the week, is that reasonable? Don't tell the speaker I told you that. Hopefully he's not. You can't watch every minute. So let me just go through what I have. HB 1585 was continued to March 20th. HB 1712, Dave Nagel, you're writing that? You're doing the report on 1712? All right, okay, I haven't checked my email. That was gone consent, so there's only one report. HB 1010, Representative Mazur? Okay. HB 1638 FN, I'm doing that one. I have not done it yet. HB 1663, Representative Leon?
Yes.
HB 1300 was continued to the 20th. HB 1028, Representative Shapiro, you're doing that one? Okay. HB 1280, that was continued. HB 1347, there's a majority report, Representative Coldfault. Okay, thank you. And Representative Shapiro, you're doing a minority report on that one? As long as I get it. Well, no, I'd like it this week. Yeah, I'd like it definitely this week.
Whole half a week.
2 days, actually. HB 1568 was continued to the 20th. HB 1607 was continued to the 20th. HB 1615, Representative Cofault. Okay, thank you. And HB 1683, Representative Leon, you're doing the majority. Representative Shapiro, you're doing the minority on that. Does that sound right to everybody? All right, I know of no other business unless somebody else has something else to say. Representative Merchant.
Thank you, Mr. Chair. I just want to be sure I have those who have a desire to look at 1300 and 1607. Will you please send me an email? I'll see if I can set up some time to talk about those bills. It'll be an ad hoc meeting. This is not going to be formal. It's just going to be us working offline.
Okay, thank you. Anything else? No, Representative Leon.
Thank you, Mr. Chairman. My thought would be that if we haven't heard back from the clerk and speaker, but we'll probably, my guess would be we try and figure out how to fit it in within our normal. Yes, we need to have a hearing on the amendment. So shall we look to do that next Wednesday, maybe 10 o'clock or after lunch, if depending on what the schedule is?
May we do it on the 20th and exec it afterwards? Right.
Well, we were hoping we would.
I wouldn't want to come in just with the one bill. Please.
So I know. I guess the question is, since we're not just doing it as a okay, then I guess
we'll have 6 bills to exec plus that hearing, right?
yes. So then the question would be how. The thing is, with 6 bills to exec, with that being a
And
deadline
those reports
day,
have to be in that day because the deadline is the 21st. So they have to be done that day.
9:30.
Not usually 9:30 works for everyone.
or do we start at 9 with the hearing on that?
We
and
can do
then
9,
start
that's even
the
better.
Executive
And
session starting at 9.
And again, everybody wouldn't have to be here at 9 for the
Yeah.
hearing.
That works.
Okay,
Why
does that
don't
work?
we start at 9 on the 20th then?
Okay.
Representative Shapiro.
Is someone going to write the amendment or have the amendment written prior to the hearing, which deals
Well,
with
it's actually on the amendment that's already done, right?
So we can do it on the amendment that's already done. If we were to add any rulemaking or the injectables, those would still be germane to what we have now.
Right,
So
but since we're doing it the same day, it seems like someone should have that amendment written.
definitely seems that way. That would be helpful if there's anything that you wanted to write or that Representative
Yeah, there
Merchant
can be
wanted to
no
write.
I'm not
continuances.
volunteering, I'm just saying. that I-
You're voluntold.
There will be no continuances that day because they have to
Which
be
is the one
done
you're
that
talking
day.
about that needs to have something written?
Anything else?
Sorry,
I'm sorry, Representative Tejas?
My question was, which bill are we talking about needs to have an amendment on that day?
1585.
Yes, so the one that we had that large amendment that the speaker has ruled that it's non-germane, so we need to have a non-germane hearing. We've already discussed most of those issues, so as long as there's nothing that comes up and makes us realize that this is a big problem, I don't see a problem with us doing it on the 20th then. And then if we realize that we've drifted into a minefield, then we adapt with that.
Madam Vice Chair?
Yeah.
Can we maybe only schedule 15 minutes for that day instead of 30? That way we can start on the executive session at like 9:15 instead of having to wait, just in case.
We probably could, but we probably wouldn't be scheduling the executive session until 9:30 anyways. So if we started at 9, so that we can do that, that way if it is a little bit longer, I'd be uncomfortable starting before 9:30 for the executive session.
Okay.
Just one note, when I wrote most of the.
Anything else?
Yeah, when I wrote most of the education blurbs, we used to call them years ago, I had them all written before the hearing, before the exec session.
Our executive sessions can be very unpredictable, as you may have noticed. Anything else? If not, we stand adjourned, and I will see you tomorrow.
No, I'll go.
No, that's not taking.